That looks like it. And please, Steven. Hello, everyone. So today I'm just presenting a typical cervical cancer case presentation, as we would commonly see in Africa, and how we would normally go ahead in terms of treatment and management of this patient. So my patient is a 3-year-old female by the name of Mrs. HM. She presented with some postmenopausal bleeding for about 3 months, some postcoital bleeding as well, and dyspareunia. She had attained MENAC at the age of MENAC about 12 years ago, at the age of 12 years, and was menopausal at the age of 50 years. In terms of the past medical and surgical history, she was a known retroviral disease for about 20 years at the time, 21 years, and was on heart treatment. She was also previously treated for TB for about 6 months, and she was a known hypertensive on treatment and had previously been treated in terms of she had an abdominal hernia. Okay, she was single, however, had 1 child with a 20-part history of smoking and no history of alcohol intake. On examination, she was quite well, performance status 1, with no pallor, no lymphadenopathy. Her abdomen was quite normal. However, on vaginal examination, she had a normal vulvar and external genitalia. However, she had a 5-centimeter exophytic cervical tumor that was replacing the entire cervix, involving the anterior vaginal wall and the lower third of the vagina, and involvement bilateral parametrial involvement with extension of the tumor into the pelvic, into the right pelvic sidewall. On digital rectal examination, there was no abnormality that was found. So histology confirmed that she had a moderately differentiated squamous cell carcinoma. On diagnostic workup, everything seemed normal. She had a normal full hemogram or full blood count. The creatinine and urea was normal. The liver function was normal. Of note is that she had a CD4 count of 567, which is normal, and a viral load that was less than detectable. So in terms of her HIV status, it was well controlled, and she VDRL was negative. Chest X-ray that we typically do for this patient was normal with no suggestive. It was not suggestive of metastatic disease. Abdominal pelvic ultrasound showed no hydronephrosis and no liver lesions. Cystoscopy was also normal. However, there was suspicion that was seen in the trigon. This was biopsied, and it only indicated chronic cystitis with no malignancy. She was staged, according to figure 2018, as a stage 3B. So in terms of how we treat this patient in our center, these patients are always discussed in the multidisciplinary team of the combined clinic. This is where we review the chest X-ray and all the imaging and the blood work that was performed for our patients. And for her specifically, she was staged as stage 3B due to the presence of pelvic sidewall involvement. The standard care for patients with locally advanced disease in terms of cervical cancer treatment is external beam radiotherapy with concurrent platinum-based chemotherapy, and external beam radiotherapy also entails treatment with intracavitary brachytherapy. So typically the radiation treatment entails treatment with 46 gray given in 23 fractions at 2 gray per fraction. And this can be done either using 3D conformal radiotherapy or VMAT, what we refer to as volumetric modulated arc therapy, using energies typically 16 MeV or 18 MeV energies. And then after external beam radiotherapy or towards the end of external beam radiotherapy, these patients are treated with intracavitary treatment or brachytherapy. Typically, we give 4 sessions of 7 gray per session. Now, in terms of the chemotherapy element, concurrent platinum-based chemotherapy is significantly important and has survival benefit for patients. And usually for these patients, we normally give cisplatin 40 milligrams per meter squared. However, in cases where cisplatin is contraindicated for one reason or another, typically these patients would be patients with hydronephrosis, patients with a poor performance status greater than 3, or patients who may actually present with a low glomerular filtration rate. We can give carboplatin in place, area under the curve 2, and this is also administered weekly. Now, in terms of the radiotherapy element, setting up of the patient is, of course, very important. Positioning and immobilization of our patients. Usually, they are typically supine with arms on the side, with the nearest and the footrest for immobilization. We create a reference point, which is a reproducible setup point using bony landmarks. This is done using both a lateral and a midline laser. And we use a planning CT. And for these patients, for stimulation, we give IV contrast. And using the planning CT, we scan in 5 millimeter slices from the sigmoid process all the way to the mid-femur region. Now, let's talk about what we delineate in terms of our target volumes for these patients. Typically, we normally have a CTV, and the CTV would actually delineate the entire cervical tumor. Not only that, you have to include the entire uterus and adnexa and the parametrium. However, usually for our patients who have stage 3B disease, our CTV also includes the mesorectum. Now, in terms of the CTV nodal volume, on the other hand, that starts from the level of the bifurcation of the aorta, where we use a 7 millimeter brush around our vessels, which would include the right and the left common iliac, the level of the right and the left common iliacs, to include the internal, the external, the presacral, and the obturator nodes. For patients, I must mention, for patients who have tumors that extend to the lower third of the vagina, then for such patients, you have to include the inguinal nodes. However, once we have our CTV tumor and our CTV node, we typically add a 1 centimeter isotropic margin around the tumor and a 7 millimeter isotropic margin around the CTV node. And that is bullied together in terms of having both a PTV nodal volume and a PTV tumor volume that is treated together as PTV 46, and that is our main target volume for treatment. Now, organs at risk have to be delineated, including the bowel, the femoral heads, the bladder, as well as the bone marrow. Currently, there are studies that have shown it is important to delineate the bone marrow as a target volume as well. Now, in terms of the prescription, again, we treat these patients with 23 fractions. So the total dose is 46 gray, given in 23 fractions at 2 gray per fraction, normalized to the target volume, which is our PTV. Now, beam arrangement, again, we talked about these patients can be treated with 3D conformal radiotherapy, or they can be treated with volumetric arc therapy. In our center, most patients are treated with beam arc, but for this patient specifically, she was treated with 3D conformal. And in terms of the beam arrangement, you would normally have an anterior beam, a posterior beam, and 2 lateral opposing beams. Usually the energy is 18x. Energy or MEV, the MLCs are static. However, you might find in this case, the posterior beam was weighted a bit more than the rest, and that is a typical 3D beam arrangement we do for cervical cancer patients. So this is an image that shows what appears in red is our PTV. At the center of the PTV, you can see the uterus and the parametrium, and you can see the anterior, posterior, and the 2 lateral beams that are used for treatment. Now, coverage, very important. Again, we have to use the ICRU guidelines, whereby what is required is a target volume in terms of coverage between 95 and 107%. For our patient, it was about 98 to 102, and it was acceptable. So this is an image that shows how you assess the coverage using a dose color wash. Sometimes you can use the isodose lines as well to assess adequate coverage and conformity of the treatment to the target volume. So it's important to evaluate in both axial, sagittal, and coronal views. Now, I'll just mention a bit about intracavitary therapy. Typically, you have to always do what we call a checklist to ensure that the patient is fit. That is blood work, a chest X-ray, an ECG, an INR when required. And of course, the patient should be NPO prior to treatment because they will normally require a spinal anesthesia. So this is our worksheet typically that we did for our center in terms of our patients. So there is always pre-assessment, which is the examination of the local disease that is residual. However, there has to be an ICT checklist. The patient is under spinal anesthesia. The patient is usually positioned in lithotomy position. And ideally, you have to insert a catheter with about 7 cc's of a radio-opaque fluid. That is very important because that helps you to assess when you're imaging the patient. We use an S-tube, that is used once the cervix has been dilated and imaging is done. If the physics team is happy, then we can go ahead and treat. However, if there are any issues in terms of positioning of our patients, then we have to first re-image before we can treat. So positioning during brachytherapy is very important. So this is just an image of our typical brachytherapy suit. And that is also an image of our brachytherapy suit as well. So in terms of applicators, what we use is tandem and ovoids. You can use tandem and rings. You can use whatever you might be available. So this is an image of the tandem and ovoids that we typically use. You can use tandem and ring as well. What appears posterior to the tandem and ring is a rectal retractor that reduces the dose being delivered or any dose fall off to the rectum. This is also referred to as a combo. This is where it has, you can treat for patients who have tumors that extend into the lower third of the vagina, whereby it's a combination of a cylinder and also intracavitary into the uterus. This is a typical example of our patient. And you can see that image there shows the typical example of how the tandem looks like from the outside. This is what is inserted into the patient, and you use a stand to ensure that you have adequate positioning of the patient. That is what we use. So what appears in white is what is referred to as an afterloader with tubes that deliver radioactive isotopes into the patient. And this is when, once we are ready to treat the patient, we actually insert the tubes and ensure everything is attached to the afterloader, leave the room, and therefore the treatment is directly treated into the patient to reduce any radiation that might affect the radiation oncologist or the physics team during treatment. So usually we use an afterloader for our patients. So let me just talk about 2D imaging for a minute. This is how you expect the brachytherapy to be inserted into the patient. You can see the tandem and the ovoids as well in position, both on the X-ray as well. And this is how the imaging is done. And this entails both an anterior and a lateral image. So dose distribution during brachytherapy, we normally just prescribe to what is referred to as point A, which is usually 2 centimeters superior and 2 centimeters lateral. And this is where we want 100% of the dose to be delivered. And typically, it's what is referred to as a pear-shaped dose distribution. Now, in terms of side effects, acute and chronic, quite important to detail in terms of what the patient may be struggling with. commonly nausea and vomiting, of fatigue. There might be some skin irritability, urinary symptoms, GI symptoms as well, and also chronic side effects such as intestinal obstruction, urinary symptoms, GI, and also formation of fistulas. So what happened to our patient? She was able to complete intracavitary treatment well and external beam radiotherapy concurrently with chemotherapy, and she was able to complete treatment within 8 weeks. Actually, for patients with cervical cancer, the treatment time should be reduced to no more than 56 weeks because 56 days because it significantly affects the outcome of this patient. So how do we follow up the patient? 3 monthly for 2 years, 6 monthly for a duration of 5 years, and discharge the patient thereafter. Thank you very much for listening to my presentation.
Thank you, Dr. Juliet. There's a couple questions in the chat. I don't know if you had a chance to look at them. One person asks, why do ECG for ICBT patients greater than 50 years old?
So typically for all our patients who are above the age of 50 years, who are actually hypertensive, is not every typical patient above the age of 50 years, but those ones who are 50 years and are hypertensive, for anesthesia implications, they have to have an ECG. That's the typical guidelines in our center.
Okay. Also, I'm not sure if you can see the chat or not, but there are a couple other questions in there. So one question is,
there's a question whether we evaluate response at 6 weeks.
Mm-hmm.
Yes, we do. So typically we would normally, the first visit would normally be 6 weeks post-treatment, then 3 monthly, then 6 monthly thereafter.
There's a question on ORR.
Was the rectum not included in our organs at risk? That's a very good question. Very good question. Yes, there are guidelines stating that you should include the rectum as part of your organs at risk. We haven't typically done it because constraints our ability to actually know the dose that is delivered directly into the rectum, especially after brachytherapy, has been quite difficult. However, that being said, with the advent of image guidance, there has been a much better way to be able to delineate and assess the constraints to the rectum. So typically you should when the resources are available. Someone asked why we give 7 gray in 4 fractions. It is not written in stone. The actual dose varies. So typically it's anywhere from 6 to about 7 gray given in 3 to 5 fractions. The most important thing is that when you want to look at the cumulative and the total dose, combining both external beam radiotherapy and brachytherapy, the typical dose should be a total of 70 to 80 gray in terms of the equivalent dose. So that is the most important thing. In our practice, there's someone who states that they give 7 gray in 3 fractions. That is still acceptable, but then again, you have to remember the total dose cumulatively should always be anywhere between 70 to 80 gray. I would.
There's also one question in our
question in terms of proposing for surgery after treatment of residual disease. Usually, typically, if a patient presents at about 6 weeks with some residual disease, we do not jump into surgery immediately. So we would normally review them again in about 4 to 6 weeks. In the presence of still residual disease, this has to be rediscussed in a multidisciplinary team. Then remember, the approach of treatment of cervical cancer is not from an individual perspective as an oncologist or as a surgeon. Then if the patient has residual disease, has a good performance status, then that is things you can discuss in terms of resection. And of course, the morbidity associated with a pelvic exenteration is quite extensive. But yes, that is possible for patients with residual disease with a good performance status and can be able to adequately be treated. How you evaluate residual disease by imaging or biopsy obligatory? Yes. So if a patient has residual disease or what you suspect is residual disease, certainly be able to biopsy that. Because once you biopsy, then you start from square one. And what that means is that once you biopsy, you confirm that there is residual disease, then you must re-image the patient and then treat adequately according to the decision made in the multidisciplinary team. Patients who are fit definitely are candidates for surgery in the presence of residual disease. What was the dose to the bladder point and the rectal point during? So in terms of intracavitary therapy, we normally use the ICRU recommendation. So it depends on the total dose. According to the current guidelines, they say about in terms of the total dose cumulatively with external beam radiotherapy and brachytherapy should be no more than about 70 to 75 grams. So in case of having external beam radiotherapy or BIMA, which technique is preferable for non-operative cervical cancer? Very good question. So I suppose you are asking in terms of 3D conformal radiotherapy or volumetric arc therapy. Volumetric allows modulation of the fluence of the photons to the target. It actually allows a much more conformal dose to the target and reducing toxicity to the organs at risk. In our center, what we've done is that a lot of patients are transitioning away from 3D conformal, and we're having more patients being treated with VMAT. The only issue is with VMAT is remember the integral dose is quite high. And that is something to always think about. But definitely in terms of conformity and reducing toxicity to organs at risk, VMAT is the way to go. And it is currently what we are transitioning into. If brachytherapy is not available, can surgery be allowed? Okay, that's a very good question. So what we do in our center, we have patients whereby typically they are in the brachytherapy suite and we are ready to put in the tandem and the ovoids and the applicators. And brachytherapy is not possible in terms of very large tumors that have not really shrunk down, or in terms of accessibility and patency of the cervix into the uterus. So typically what we would do for such patients, we give an external beam boost. Now, an external beam boost is directly only to the cervix and to the uterus, and we give a total of about 18 to 20 gray for patients who brachytherapy might not be possible. So instead of doing surgery, we actually give an external beam boost. For the patients you presented, what was the interval between external beam radiotherapy and intracavitary? Then usually, I have to emphasize that treatment for patients with cervical cancer should be no more than 8 weeks. So what is important is to ensure that the brachytherapy comes as soon as possible. So what we do in our center is that towards the last week, which is usually the 4th week of treatment, we start treating them with brachytherapy and then continue with the external beam therapy. So typically we don't wait. As soon as we can, is that whereby we ensure that the patient's treatment is as short as possible. So there is no interval. Towards the last week, usually we would give about 20 fractions and then give the intracavitary and finish off with the external beam radiotherapy and then finish off with the intracavitary brachytherapy. Okay, there is a question on, do you use image guidance during applicator insertion? No, we do not. We currently do not have a CT or an MR base. That is what is happening in some centers. In our center, we still use 2D, and 2D is efficient, but that is what we use. And the 2D our form of image guidance that helps us to connote whether we have been able to place the applicator in position as required. But in centers with availability of a CT and MR image-based treatment, that can be done and is very effective. Actually, there are many trials that have currently ongoing and have been conducted with review to image guidance. So someone
Dr. Juliet, can you raise your voice a bit, please? I think maybe you were away from the mic.
Hello, can you hear me?
A bit,
Yes.
Yeah, but you know, if you can raise your voice, will be better if you don't mind.
If I raise my voice, it will be better.
Yeah.
Is that better?
Yeah, that's better. Thank you.
Okay.
Thank
Great.
you.
So the other issue is that in terms of tumors that are more than 4 centimeters, which applicator would you use? Typically, it is even in large tumors, you can still use a tandem and ovoid. The only thing is that with the tandem and ring, for patients who have more barrel-shaped cervix, you may consider using it, but any of the applicators may typically be used. Of note is just remember, if a tumor is extending into the lower third of the vagina, you must use a combo, which entails both a tandem and a cylinder for adequate treatment of such patients. But even for large tumors, we still use a tandem and ovoid for these patients. Should the equivalent dose be 70 to 80 or more than 80 in terms of the EQD2 local advanced disease? Typically, according to the current guidelines, it should be anywhere between 70 and 80. Then again, you don't want to go too high because of toxicity to organs at risk. Someone inquires in terms of use of MRI for delineating target volumes in brachy. Yes, that is done in some centers and has been very efficient in terms of reducing toxicity and also conformity to what you want to treat. So MR-CT-based brachytherapy is the way forward, so to speak. And even in our center currently, what is happening at Fortescue Hospital is that they are moving forward into CT-based brachytherapy and probably MR-based brachytherapy in the near future. What is the ideal time between EBRT and brachy? The most important thing is to remember within 8 weeks, treatment should be complete. That means within 56 days, you should have completed both EBRT and brachytherapy. What protocol do we use in terms of bowel prep? Typically, what we do for our patients is that prior to scanning the patients, we normally do a scout image at the CT simulator. And what that means is that we are able to see prior to scanning how big the rectum is. Typically, if the rectum is anything more than 4 to 4.5 centimeters, we will not scan the patients and we will rescan the patients. So what we do is that we ensure that the patients are on laxatives or even suppositories if available. If the cervix is quite large, there has been times we've used fleet enemas, but the problem about that is that it now creates a very large vacuum of air in the rectum. But typically, we would normally give them Sina, Ducolax, any of the laxative prior to simulation and also during treatment, because you want to ensure that the rectum is the exact same size. Many centers use MR for delineating target volume. That is correct. And that has happened. As we have mentioned, we are currently using 2D, but we are eventually going to move to 3D CT MR-based brachytherapy.
The question by Dr. Abba. He raised his hand.
Hello, good afternoon, good morning.
Good morning.
Yes, thank you for the excellent presentation and overview about cervical cancer. Just one question. Do you do hypofractionation for cervical cancer radical patient or not?
That's a good question because the topic is about hypofractionation. So typically for patients who we are going to treat for definitive or curative intent, we have typically used convectional fractionation. However, that being said, for patients who are being treated with palliative intent, a lot of times we have hypofractionated, and typically we would normally give about 5 gray in 4 fractions or 3 gray in 13 fractions for a total of 39 grays.
Okay, thank you. Right. Just I don't know on the audience, is anyone treating radical cervical cancer patient with hypofractionation in the current state? Even though we're all aware that we have a limited data to support that, but it has been practicing in some of the centers. And as we know, cervical cancer is one of the leading malignancy in the developing country, and including South Africa. I think cervical cancer is associated with high mortality. So the waiting time of radiotherapy across the African is quite something that is not to mention, and hypofractionation has actually a better something for us on that. I do hypofractionation here, so I just want to hear from the audience if anyone is doing hypofractionation. Otherwise, I will just share a bit of our experience of hypofractionation for radical patients.
Maybe we can have a show of hands from the participants if you do hypofractionation. Again, if you do, I guess to answer Dr. Aba's question, if you can raise your hand if possible. I'm not sure if people have that. Okay, yeah. I mean, I see 4 hands raised. So maybe Dr. Aba, maybe you can share a few minutes.
Right. So basically, in average, I base in Durban. KwaZulu-Natal is one of the provinces in South Africa. Probably we may have a high turnover of gynecological malignancies, and particularly cervical cancer. In average, I see about 20 to 25 cervical cancer per week. And obviously, most of the patients are locally advanced, stage 3 to 4, and very few of stage 2. In my hypofractionation, I give them a 16 fraction of 2.67 gray without a chemotherapy. So, and after that, I followed them with a brachytherapy of 21 in 3 fraction, just because of the waiting time. And some of them, I give them 9 gray in 2 fraction, well tolerable. Most of these patients, prior to treating them, I do a PET CT, and on the PET CT, one of the rationale or reason behind, more often than more you can get them with a para-aortic node, which entirely change the management, especially if it is above the renal hilum. Then chances of curing them is not there, and fairly we have a very reasonable local control response, and there are quite few things that we are doing which are on the 5 line to be published on due course. And I think it is something to be considered, because if you are given 16 fraction, literally you will reserve 9 fraction to conventional treatment, which will accommodate more patients. Waiting time in average is about 4 to 6 months, depending on the centers. And some in the African, I think is something that to be considered.
I have a question for Dr. Aba, Stephen. So do you, since you're doing hypofractionation, the imaging will play a critical role in delineation of the target volume. Do you do any MR-based delineation of the target volume?
Now, what I do is that, so I do my staging PET CT. We are trying to, so I do a matching of this PET CT, and then based on the PET CT, we can do a biological target volume. Then we go on the PET CT because we can see the functional of the disease.
Yeah, I guess a key comment that you made there is the margin. You know, in the absence of MR, since the target volume cannot be seen very well, it's important to have that extra margin in there.
Yeah. I hear what you said. Definitely in the margin, we do consider, but of course, if you do a PET CT, you will see the active biological disease or metabolic disease, whereby you may be able to have a clear-cut idea of how the extent of the disease, and that will guide you on considering your margin. Otherwise, we consider the standard margin on the guideline.
Thank you. Yeah, many centers, as Dr. Juliet mentioned, and we do the same. The MRI-based brachytherapy is what we practice typically. You know, we place the, bring the patient in the morning, and the ultrasound guidance applicator is placed, and CT is used to confirm the placement of the applicator, and then you do an MRI, and then the physicians draw the target volume on the MRI, and the information is sent to the Centra treatment planning system. So we do our treatment using the MRI based guidance, as well as the 4-hour VMAT is what we use. So that actually helps in delineating target volume very accurately. And then also an important thing is also after you do the external beam, one does some imaging to really make sure whether the target has shrunk. In many cases, if the target doesn't shrunk, then you gotta think about how do you treat that extended volume of the disease, right? There are, again, in the advanced centers, there are people use applicators like Valencia applicator and other VN applicators to be able to treat the disease that has not regressed. So yeah, Dr. Juliet is right. The use of use of MRI guidance treatment has really helped in the reduction of the toxicities at many centers.
Excellent.
Sure.
So, Dr. Julia, I know we have about 15 minutes left for, I guess, your session, but there are a few more questions in the chat, and there are also about 6 questions in the Q&A. So just let everyone know, if we don't get to all the questions in this session, we have a dedicated Q&A at the end of our session that we will address the questions. And if, again, I know this is a very, very popular topic, if we don't get to all the questions, we will follow up with any questions we were not able to answer during the course. So Dr. Julia, I don't know if you saw the questions in the Q&A also. There are about 7 questions there.
I'm just looking at the chat. There's someone saying there are many African experiences but not published because they have a lot of patients in the waiting list and extremely hard. About 8.
Oh, sorry, Dr. Julia, could you move a little closer to the microphone? I know it's.
Oh yeah, can you hear me better now?
I don't know, maybe wherever you shifted were before, it was good. I don't know where. Can you go?
All right. Let me see.
I mean, that doesn't sound too bad. Is everyone okay with that? That sounds
I hope you can hear me.
Yeah.
Okay, let me take a look at the questions in the chat. Okay, I can see the questions in the Q&A. The question is, if brachytherapy is not available, can surgery be allowed? So I'm assuming, do you mean external beam radiotherapy, or just brachytherapy? Because if just brachytherapy is not available, then such patients can be treated with external beam radiotherapy with a boost to the target. So you treat with anywhere between 45 to 50 gray, and then you can give a boost of about 18 to 20 gray. In our center, we give 46 gray to the target volume and an external beam boost of about 18 gray. So if there is no brachytherapy, you should treat with external beam radiotherapy and a boost. If there is no external beam, radiotherapy, then that becomes quite difficult. I have seen in some countries which do not have radiotherapy, such as Malawi, typically they try and shrink the tumor with chemotherapy and go ahead with surgery. But of course, such outcomes are not very good because the standard of care is radiotherapy for patients with locally advanced disease. There's a question about limitation of point A, and that is very true because point A is a point that can vary. So sometimes the 100% isodose line might not, typically if the tumor is very large and the uterus is very large, you might find that the target that you want to treat is outside our point A. And if the cervix is very small and the tumor is very small, then you may find that the target you want to treat is outside point A. So those are the limitations when it comes to using 2D imaging. And that is why, yes, in terms of having high-risk CTV dose, in terms of image guidance is very important. He says point A dose is not a good surrogate for target dose. I agree 100%. However, in the absence of image guidance, that may be used, but in the presence of image guidance, definitely you must use the intermediate risk and the high risk CTV as your target volume because it significantly reduces toxicity to our organs at risk. What about chemotherapy? Is it associated with brachytherapy? Typically, you give chemotherapy weekly. So normally, most patients would normally get anywhere between 5 to 6 cycles of chemotherapy weekly. And that is not related to brachytherapy. It's just the treatment that the patients would get on a weekly basis while they are on treatment. So there is Salim who says the problem is target volume coverage assessment. Dose prescription is not linked to target volume coverage based on imaging and quality of the implant evaluated by localization film, point dose calculation, and isodose curves. That is very true. So that is the typical problem or challenge that we face when you have only the availability of 2D imaging. And that is why transition into 3D is crucial and very important. Yes, I agree, we do have the ESTRO guidelines that have actually shown and recommended how to treat these patients with image guidance, and also especially brachytherapy. So there's a role of neoadjuvant chemotherapy is advised for large tumors. There was a trial that was conducted actually, and there were 2 trials. One trial tried to look into the role of giving neoadjuvant chemotherapy. Another trial tried to look into the role of giving adjuvant chemotherapy, and actually both showed that there was no survival outcome. So typically, currently, even for large tumors, the standard of care for patients with locally advanced cervical cancer is concurrent platinum-based chemotherapy with radiation and brachytherapy as a standard of treatment. Treatment of para-aortic nodes after external beam radiotherapy and brachytherapy. So treating of para-aortic nodes becomes very difficult because of toxicity that the bowel normally faces, and that is quite a challenge. We have patients we have treated with para-aortic nodes, and for such patients, we treat them with BMAX if possible, because then it does reduce the toxicity to our organs at risk. So yes, we can treat patients with para-aortic nodes, and we treat them typically, we would normally go 2 to 3 centimeters superiorly to the para-aortic node that is involved, and the typical volumes that are contoured for cervical cancer, followed by brachytherapy. Patients, any recommendations when you treat infrarenal para-aortic lymph nodes electively? So again, patients with para-aortic nodes, I'm talking about a patient with a good performance status who you want to treat with definitive or curative intent. You must definitely contour or include the para-aortic nodes into the target volume currently, and then once completed, must re-image to see if there was actually any response to treatment or not. That being said, patients with para-aortic nodes typically have a very difficult or a poorer outcome.
Okay. So Dr. Julia, maybe this is a good time to pause because we want to move on to our next speaker. If possible, I mean, you could look at the chat and maybe try to answer some questions through the chat, but we will have, about 20 minutes at the end of the session to answer some questions. But I know that, again, there are a lot of questions coming through for you, and there will be other speakers that may address some of the questions also that may be similar. But I think that just for the sake of time, we want to move on to the next speaker. I think Dr. Julia gave us a very nice overview, introduction into what's necessary for the treatment and care of cervical cancer. And now we're going to go into a little more detail from some of our other speakers. So our next speaker is Dexter Wilson, who is a radiation therapist at the University of Pennsylvania. And so although he works on many different sites, I think he will discuss the setup and localization that's necessary from a therapist point of view in order to treat cervical cancer. So I do have your talk, Dexter. I'll bring it up for you, and then you can just let me know when you would like slides advanced, and I can advance them for you.
All right, thanks, Steve. Good morning, everyone. Can you hear me?
Yeah,
hello?
I can hear you.
Oh,
I can hear you.
Okay, thanks very much. So I'm just gonna talk a little bit about the things we do at University of Pennsylvania to prepare patient for simulation and delineation of the treatment area for external beam radiation. Steve, can you go ahead? And one of the critical things we do involves immobilizing and reproducing the treatment site and the treatment area. And some of the things we do to achieve that requires that we ensure before we go ahead that certain critical things are covered, certain critical things are met. First thing we do is we have documented physician instructions, which tells us the area of interest for treatment and the treatment goals.
Oh, Dexter, I'm sorry to interrupt, but I know I gave a brief introduction. Maybe you can tell the people who are here just a little bit about yourself and your role. I mean, I probably was very brief, but just to give them a little more detail, exactly, what you do as far as at University of Pennsylvania.
Oh, okay. So I'm a radiation therapist. What we do is we simulate, scan, and also treat patients with external beam radiation. We specifically do external beam, although many of us also are involved with the brachytherapy. Our role is distinct from the physicist and from the nursing team, because we specifically do deliver the radiation treatment. I've been a radiation therapist since 1998. I've been at Penn since 2008. I worked at a few other sites along the East Coast over the years. And because we've settled in Pennsylvania, in Philadelphia, I'm fortunate enough to be a part of the University of Pennsylvania team. And that's basically a little snippet of who I am. How's that? Does that
Good. Yeah, thank you. Yeah, go ahead.
Okay. All right, thanks. All right. So to pick up where I left off, so some of the critical things we have to identify before we proceed with treatment and simulation. We have to have clear documented instructions for the area we're treating and the goals we want to achieve in treatment. We need to identify any prior areas of irradiation that the patient's received. We have to confirm documented diagnosis of what we are going to treat on the patient. And we have to identify with fiducial markers that'll, if there are any pre-radiated sites within the treatment area. We do that by attaching little metal BBs to the surface area of the patient, and those show up in the CT scan. Mostly we are able to simulate patients in a supine position if the patient is able to tolerate laying flat. We use as minimal as possible tools in achieving this. Just a comfortable pillow. We use a comfortable square pillow under the head, a little wedge under the knees just to keep the patient back in a comfortable position. If it's necessary, we can achieve frogging the patient's leg by creating a vac lock device, which is something that just deflates and forms to the patient's shape and will help the patient to keep their leg in the position that we need to achieve. Also, to get the arms up and out of the way, we'll use something called a wingboard, which is just a device with some pegs above the patient's head that they can rest their arms on, and it has some support for their elbows to just rest out comfortably. And if a patient can't tolerate their arms above the head, we'll just basically have them folded on their chest about as high as possible. So that limitation is based on the patient's physical abilities. Next slide, please. We have to, we ensure that the patient's arms are well out of the way of any treatment fields, and we also scan parameters above and below the area of treatment. So we will scan a patient from, say, the middle of the abdomen, somewhere below the chest, all the way down to about the middle of the femur to achieve that. But it's critical to ensure that the patient's comfortable, that the patient's in a position that they can tolerate laying in for a half hour to an hour, and that it's consistently reproducible in order to achieve successful treatment delivery. If you have a patient that's uncomfortable, they'll move on the table, they'll squirm, they'll readjust, even if they don't intend to. Next slide, please. These are examples of some of the devices we use to achieve the immobilization. The first one, the one on the left, is just an example of the simple basic head pillow, knee cushion, and the we called it the one at the very left, foot lock. It allows the patient's feet to be in a fixed position and keep it from sort of flopping out or in during treatment. The patient can get fidgety and sometimes move their feet from side to side, and that will affect the positioning of the tumor during treatment and simulation. So we use this to just keep their feet in a fixed position. On the right, we have an example of what the Vaclock bag, it initially is just sort of loose like a bean bag, and the patient's laid in it and the air is vacuumed out, and it conforms to the patient's shape, and you can fix the legs and feet in the position you desire, and that's what that's used for. Next slide, please. And these are a few other things. There's the wing board at the top on the left picture, and sort of a little safety belt or a little ring that they can hold on to for positioning of their arms, and just to help keep them safe on the simulation table and keep them in a fixed position. Our treatment tables are very narrow, and often if you speak to a patient, they tend to want to turn towards where your voice is coming from. So this ensures that they remain on the table and don't inadvertently turn and fall off. Next slide, please. It's not always achievable. The treatment site is not always achievable in a supine position simulation of the treatment site. So often when you have a patient with a large belly, a pendulous abdomen, sometimes that will intersect the area that we need to treat. You have the pannus that hangs over the patient's pelvis. And so in order to achieve that, sometimes we have to simulate the patient in a prone position. We do that with something called a belly board. A belly board is a device that is sort of somewhat ergonomically shaped towards the patient's body, and it has a opening in the center which allows the patient's abdomen to fall into that space and up and away from the pelvic area. We could also use some of the belting devices to help hold the patient in the position that you need. And it's more critical for safety because the patient's not only on the narrow table, on top of the narrow table is this belly board device that they lay on. So you have an added degree of concern when you have a patient in the prone position on the belly board. But this is very effective in allowing to treat patient with a larger body construct with, to help get some of those areas out of the treatment field. Next slide, please. And this is an example of that belly board. And the head goes to the top, and this is the opening that allows for the patient's belly to go in. And a little cushion under the ankle helps to relieve some of the pressure on the patient's pelvis, because they're, to keep their legs from hanging down and putting pressure on the pelvis. Next slide, please. So just to touch on some of the things we do during CT before I talk about the after CT. So during CT, once the patient is comfortable, once the position and immobilization is achieved, like I said, we'll do a scan to include areas above and below the area of interest, the treatment area. We'll acquire the CT, and then we'll identify the surface coordinates to reproduce that position with some marks, we can use tattoos, or we can just draw on the patient and put some clear stickers, some clear bandage stickers over the marks to help to maintain them over time when they come back for treatment. After the CT scan, and we mark the isocenters, we take several pictures of the area we've marked. We describe the patient positioning, and we, ensure that the reproduction and the immobilization is achievable. We, the critical thing is the reproduction of the simulation site. The critical thing is the reproduction of the patient position over time. I think, some of these patients are treated 20, 25 times. And so you have to reproduce that position time and time again, basically achieving the same thing. The patient's then taken for a PET CT and an MRI. The PET CT and the conventional CT can then be overlapped and used in planning for treatment planning. We may use we have a PET CT scanner in our facility, but we may use a PET scan from an outside facility to overlap the conventional CT for planning. Next slide, please. And here's an example of, on the right is the conventional CT that we use, and on the left is a outside PET CT. And this is what we would overlap to assist in the treatment planning.
So I believe that this will be Shibu's section in treatment delivery, correct?
Right.
So I think what we want to do, I think it may be a couple questions.
Yes.
That are in the chat. I don't know. Can you see the chat?
I can. Yes.
Okay. I'm not sure if they are directed towards you or towards the previous speaker, and also maybe some questions in the Q&A. But I'm looking at see what questions would be focused on for you. I don't know if you can see the Q&A also.
I can. Yes.
Okay.
Yeah, I don't see any questions that is directed to me.
I think those questions, Dr. Stephen, were directed to the previous. Here one of the questions by Nazlinda is saying, is there any bladder volume protocol for SIM?
Yes, for simulation, we do a scan with the patient's bladder full, and then we have the patient empty their bladder, and then we rescan them with an empty bladder. So we have both sets of scans for comparison.
Okay. Any recommendation for safe ink that could last for 20 days, for example, instead of patches?
Yes, so we use there's a product, an ink that is UV light sensitive, and so it's not visible normally on the patient's skin, but we use a UV light to see it, and patients tend to tolerate that ink. I don't think I've ever had a patient who reacted to that ink, but of course, you'd have to assess whether the patient has allergies to certain things. I don't know the name of that product, but there's a UV light ink, and there's also a standard black ink. I think it's referred to as Indian ink or India ink. It's just a black, I think it's a formaldehyde based ink, or at least it smells like formaldehyde, that we use for a time. And we just used a little needle and put a dot right at the center where the laser intersects to identify the isocenter on the patient's skin surface.
Okay, there's a couple more questions coming in on the chat now. Do you simulation with full or empty bladder?
Yeah, we simulate with both full and empty bladder, but the treatment with full or empty bladder is dependent on which protocol and what the volumes that are achieved either with full or empty bladder that the physician wants to treat. Yes, we do use contrast during simulation. Yes.
Someone did ask a question about scanning patients twice as simulation as extra dose from a radiation protection point of view. What is the rationale for scanning after emptying the bladder? I don't know if that's a question for you. I mean, if you want to go ahead and answer, Dex, or we can also ask.
It's just to give you a perspective of how the anatomy presents itself with a full or empty bladder. I can't say what the radiation dose effect is, but I don't think the simulation doesn't deliver any dose to the treatment area because it's all superficial. It's all low voltage X-rays, kilovoltage X-rays. So it's not contributing anything to the treatment dose.
Okay, I don't see any other ones right now. Oh, do you use vaginal marker during simulation?
Yes, there's often a fiducial mark placed on the external anatomy of the patient, just to delineate the surface.
There are a couple more questions that came in. I don't know if you can see them, Dexter. Well, I think one is a comment and one might be a question. Yes.
So if the patient loses weight during treatment, we will do what's called the we'll do another CT scan, and we'll compare it and overlap it with the original CT scan, and then make adjustments accordingly.
Yeah, one of the question is, do you use contrast for the simulation?
Yes, we do use contrast. We use contrast, ISOView contrast, which collects in the bladder.
Yeah, and here there is another question about adaptive radiotherapy. So in case of during the treatment process, there was like during the offline review, the doctor noticed that there are some changes in the tumor, for example. So do you have any kind of protocol that you need to resim and recontour and
Yes, so we do a scan if the patient has lost weight, if there's some drastic change in anatomy, for any reason, and we compare that, we overlap that with the original CT and the original volume plan, and then can make changes accordingly. So yes, adaptive protocols are always in play.
Okay, I think that might be a comment. I think using both full and empty can eliminate the target in both situations and fuse them. This allowed to not miss the target, even the bladder size. Okay. That's more. I know there's some questions in the Q&A. I don't know if, Maya, can you see the Q&A?
Yeah, no, there is no questions from on the Q&A. All the questions are on the chat box.
Okay, all right. Okay, I thought I see 8 questions in there. I didn't know. I can't open mine now.
Yeah, here one of the question: how do you confirm adequate bowel preparation before simulation?
There's when the patient comes in for simulation, there's a nursing session that they go to. During that session, there's things such as a pregnancy test, a bowel prep, which can, before the patient comes in, actually, they're told to go through a bowel prep process. It may involve laxative, hydration, and then when the patient comes in for simulation, if there's an issue in the patient clearing their bowel, they can be administered an enema or anything like that to help to clear out the patient's bowel. And that's a standard process with every pelvis simulation that we do.
Yeah, I have a question also, Dexter, if you don't mind. Like, do you use maybe ultrasound or so to define or to determine the volume of the bladder before the treatment, or you just use the CBCT and based on that you go on with the treatment?
We use the CT scanner, and we do what's called a scout. And so once we've put the patient in position, we'll do a scout CT, which will give us some preliminary views of the bladder and the bowel if the patient needs further prep or more time to fill their bladder or empty their bowel. We don't use ultrasound.
Okay, thank you.
So Dexter, I know that for cervical, we may not do hypofractionation, but in general for hypofractionation from a therapist point of view, like what are some of the issues that you think about or that people should be aware of when you are doing hypofractionation?
So in scanning for patient receiving hyper, the critical thing from our perspective is the reproducibility of the patient position and achievement of treating the goals, because the dose is often so much higher, and the rectum is so much more critical in that situation. So it's very important to achieve a minimal rectal dose delivery as possible, and that will be achievable by attaining a very reproducible patient position. Mostly it's a physical constraint from our point of view, and if the patient can achieve those physical goals, then it's easier to deliver accurate treatment.
Okay, well, maybe I can ask in a different way. Like what would you do differently from conventional treatment versus hypofractionation? Are you doing the exact same thing, or is it something?
Yeah, we are doing the exact same thing. The challenge presents itself when you have a patient who can't really tolerate the positioning, because then it's the positioning is critical. We won't do anything different if the patient is able to tolerate the position and demonstrate that they're able to remain still and remain in that position for the period of time it takes. The challenge comes in when the patient can't achieve those positions. Then we'll have to be more inventive in how we position and immobilize the patient.
Okay.
Dr. Stephen.
Yeah.
If you allow me, I want to remind everybody joining this session to fill the pre-assessment survey, and I will share the link now in the chat box.
I guess there's probably was another question just popped in, so we can probably have time for one more question.
So oftentimes a patient with colostomy, of course, it depends on the position of their colostomy, but oftentimes it's not an issue. We make sure that the colostomy is empty, or the urostomy is empty when they're laying on the board, but the board is designed such that the open space allows for that device to fall into and away from any restrictions. But that's of course dependent on the patient and the position of those devices.
Excellent. Okay. Yeah, thank you, Dexter, for great presentation and great discussion. I hope you are able to participate in the Q&A at the end of the session. There may be more questions that may pop up throughout.
Yeah, I'll be here. I'll be here.
Okay. And just to remind everyone, again, that the link for the assessment survey is in the chat. And also, again, we will be recording the session, so people who register will have access to the recordings also.
So there's a question about the volume, determining the volume of water in the bladder.
Okay.
We aim to achieve a full bladder. We don't want the patient to be uncomfortable where they're squirming, but we want a nice full bladder. Some of that will be contributed to by the contrast, but we often tell the patient to drink about 16 ounces of water, and we give them some time. And when we do the scout, if we see the bladder is excessively full, we'll have them relieve themselves and try to attain a comfortably full bladder for the full bladder scan. So it's a judgment call. And once we scan, we achieve a comfortably full bladder and we scan it, the bladder volume is identified during the planning session, and that's what we try to achieve throughout the treatment as well. We try to reproduce that as well, if we're treating the patient with a full bladder.
Okay. All right. Thank you, Dexter.
All right. Thank you.
So we're going to move to our next speaker, Dr. Shanaz. Sorry, Dr. Shanaz. Hope I'm saying your name correctly. Can you try to see if you can share your screen? If not, I can pull up your.
Can you see that?
Yep, see it. Can you?
Okay, great.
Can you do it in show mode? Okay. So let me do a brief introduction for you.
Sure.
Dr. Shanaz Basa, she is head of the radiation oncology at Steve Biko Academic Hospital at University of Pretoria. She's involved in research and training with an interest in HIV-related cancers, and she'll talk to us about conventional versus hypofractionation, dose fractionation. Thank you, Dr. Basa, for being here.
Thank you very much, Stephen, for the invite, and thank you for the opportunity as well. And good afternoon to everyone if you're from this part of the world, otherwise good morning, I think. In any case, I'll be briefly covering dose fractionation in cervical cancer. I wish there was a lot more to say about this topic, but I think a lot of it is predominantly work in progress. So for the purpose of this talk, I don't have any disclosures. And hypofractionated radiotherapy is not exactly something that is a foreign concept for us. In fact, it is becoming increasingly used in a large range of malignancies. But unfortunately, the evidence in cervical cancer is very lacking. We're familiar with the use in breast cancer when it initially dropped from 25 to 30 fractions down to 15 or 16 fractions, and then now further down to 5 or 6 fractions. In pelvic malignancies, rectum cancer has long used hypofractionation, initially predominantly in the preoperative setting, and especially for patients who have resectable disease, but now recent data has been using it for even organal preservation. Prostate cancer, a lot of data has come up in the last 5-10 years on the use of hypofractionated regimens, and even ultra hypofractionated regimens. And in bladder cancer, there's also recent evidence for the use of hypofractionated radiotherapy. So the question is, where do we sit with the cervical cancer? And unfortunately, we sit quite behind in terms of the development in this particular disease entity. Let's learn a little bit and take a step back and look at the other disease entities where we use hypofractionation and look at how this has evolved and how successful it has been. In rectum cancer, initially we realized that chemoradiation was necessary after surgery, especially in patients who had locally advanced disease, in order to improve local control rates. And then we realized that the patients also benefited predominantly from preoperative chemoradiation as opposed to postoperative in terms of local recurrence and survival. And there was very many reasons for that. And thereafter came the Dutch TME studies, which showed that basically, TME surgery was superior to conventional surgery at that time. And then we looked at the short course versus long course radiotherapy, and short course radiotherapy was initially used in the Danish or the Scandinavian protocols when it was given in cases of operable disease in order to basically before surgery, which was done a week after. And now we come to the concept of total neoadjuvant therapy, where we're giving a combination of short course radiotherapy and chemotherapy prior to surgery. And more recently, short course radiation followed by limited surgery. So in rectum cancer, hypofractionation has kind of evolved and taken over considerable volume of cases that are treated now in all stages and all spectrum of disease as well. And we use a standard dose of 5 gray times 5 fractions, which was found to be safe and effective in the neoadjuvant setting, bearing in mind that these patients were actually going for surgery. And as I said, initially it was used in resectable and thereafter in advanced disease with chemotherapy. The outcomes were similar to long-course radiotherapy, if not better in the recent data. In prostate cancer, we've moved on to moderate hypofractionation. For those of us that treat large volumes of disease, this is actually a kind of a breather, because away from the 7 to 8 weeks of treatment that we're normally given to get the dose escalated approach, we're now giving 20 fractions. And this emerged after a series of studies done, in the last decade, which show that hypofractionation was actually not inferior to conventional fractionation. It was actually kind of unusual, bearing in mind that one of the reasons why hypofractionation was studied in this disease entity was because of the thought that the alpha-beta ratio for prostate cancer is significantly lower in relation to the normal tissues around it. And therefore, we were trying to exploit this in order to basically determine whether or not we could have better outcomes. But what the trials actually show is there isn't an improvement in outcome. What it certainly shows that it doesn't do worse. And for resource-constrained or busy centers where prostate cancer is very frequently treated, I think this actually results in shorter treatment times. And then we moved furthermore into the realm of ultra-hypofractionated radiotherapy or stereotactic body radiotherapy. And there's been several studies now in prostate cancer which has looked at this, and the doses are significantly shorter and higher, and basically given as 1 to 2 a week, or maybe even 3 times a week. And what's interesting is that this is restricted most often to low risk and intermediate risk cancers, but it can be used in high risk cancers, as seen by the limited data or the limited patients represented in those studies. And in some situations, like the HYPO study, 80% of patients were planned using conventional 3D conformal radiation.
Excuse me, Dr.
Yeah,
Shanad.
sure. Yes.
Some people may have trouble following you. Could you speak a little slower? Because just so.
Sure. Okay. So
Sure.
sorry, Steven. Okay, not a problem.
No problem.
Okay, thanks. Okay, thanks. So basically, when it comes to stereotactic body radiotherapy for prostate cancer, there's been recent data in the use of ultra hypofractionated regimens, and this reduces the treatment time from 4 weeks further to about a week. And this definitely is something very promising in the future. What is interesting is one of the studies, the HFRT study, 80% of patients were planned using 3D conformal radiotherapy. And it was still found that these patients did quite well with no difference in GI toxicity. There was increased GI toxicity in the first year, but it actually paralleled that of the conventional arms in the second and third years and subsequent to that. So these are very, very high doses, but we do know in prostate cancer, one of the advantages of giving high doses is that you can do it because the volume you're treating is considerably smaller. But when you're looking at cervical cancer, the volumes are considerably larger. So looking at the toxicities for hypofractionated and for stereotactic body radiotherapy, predominantly GIT and genitourinary toxicities have been studied. And as you can see, going from one fractionation conventional to moderately hypofractionated and to ultra hypofractionated, the toxicities are seemingly not greater compared to the conventional arm. So it goes to show that you can use, hypofractionated and ultra hypofractionated, and you can actually get the same results in terms of outcomes, and you can actually not bear the cost of increased toxicity. What about treating nodal disease in prostate? So this is not often done, but may be done in cases where the risk of nodal disease is considerably higher, more than 20%, in which case a reasonable approach has been to use elective doses of 25 gray in 5 fractions for patients with high-risk disease who have nodal spread. And this data recently shows that this is quite safe and acceptable. In the case of gross nodal disease, or where there's basically pathological lymph nodes, either with imaging or CT imaging or PSMA imaging, higher doses can be also delivered safely and effectively, and doses of 35 gray in 5 fractions, very similar to the dose given to the primary disease, has been found to have safety and efficacy, which is acceptable, and also acceptable long-term toxicity. Now, bladder cancer is a little bit more similar to cervical cancer, as we will see later on, in terms of its tumor biology. And with that, I refer to the alpha-beta ratio. And there have been some recent data which has looked prospectively at the use of hypofractionated regimens in the treatment of bladder cancer. There were recent study done in the UK, which basically used 55 gray in 20 fractions versus a conventionally fractionated treatment of 64 gray in 32 fractions. Once again, they used 3D conformal radiation, nothing fancy, but they did include the bladder only, which may have resulted in better outcomes. The chemotherapy used was really more toxic than what we would use with cervical cancer. It was mitomycin C and 5-FU given as bolus doses. And in this study, we also compared conventional chemotherapy, mitomycin and 5-FU, to inhaled carbogen and nicotinamide. And what they found is that it was certainly not inferior to use the hypofractionated regimen, regardless of what concurrent chemotherapy or systemic therapy that you utilize. And the incidence of bladder and rectal toxicity between the two groups was not that far apart. Another recent study looking at older patients in the geriatric population gave basically 3 gray twice a day for 8 fractions. And then this was subsequently followed by a boost dose of 2.5 gray twice a day for 8 fraction. Once again, they used 3D conformal radiation, and in this case, the lymph nodes were also treated. The chemotherapy that was used here was 5-FU once again, and cisplatinum, which was given on specific days of the treatment regimen. There was no acute grade 3 urological toxicity, and there was a less than 7% risk of acute GIT and hematological toxicities. And the overall survival rates were quite acceptable, 94% in 1 year, dropping down to about 39% in 7 years. And bearing in mind, this is an older population group, and patients who have basically localized disease, but who would nonetheless have done poorly because of the fact that they were not operable in any event. So the question we have now is, can we extrapolate all this data for other sites to cervical cancer? There's certain unique issues that we have to acknowledge in the treatment of cervical cancer. One is the dose of radiation that is required. And definitely doses of more than 85 gray to the primary tumor has been associated with improved outcomes. Brachytherapy is an essential component in order to achieve those high doses of more than 85 gray. And the type and technique of brachytherapy has also been found to influence the outcomes as well. The recent EMBRACE data with using MRI adapted brachytherapy demonstrated that with better tumor coverage, especially of the pre-treatment volume as well as the post-treatment volume, results in significantly better outcomes if the dose coverage is improved. And this can be best achieved with using combined interstitial applicators with standard applicators. The use of concurrent chemotherapy is an essential part of improving control rates and survival benefits in cervical cancer. Initially, the initial studies didn't show a benefit for stage 3B disease, but for those of us that treat a lot of stage 3B disease, subsequent data shows that we can actually use that in that disease, that stage entity as well. The pattern of nodal disease and inactive nodal radiation has also evolved considerably in cervical cancer. We speak no longer of just addressing the pelvic nodal areas, but we also talk about treating the para-aortic areas, which at one stage were considered to be metastatic spread. So elective nodal radiation to incorporate the para-aortics is an important component of treatment now, especially if you want to have better long-term outcome. And the dose of the pathological lymph nodes has also been found to be a significantly influence of long-term outcomes as well. And doses of more than 55 to 56 gray to the pathologically involved pelvic lymph nodes has been found to basically have higher control rates compared to doses lower than that. And therefore it necessitates certain advanced technologies like DMAT and IMRT, which may not be always accessible to high volume centers. So there's definitely a dose response, as I mentioned earlier. If you look at this data, we're comparing the intermediate risk CTV versus the high risk CTV, which is the pre-treatment volume, and versus the post-treatment high risk volume. And there's definitely, this bubble plot definitely shows that the local control probability will improve with increasing dose to the primary tumor. What is also important is that there are other factors that influence the outcome of the disease. This includes the tumor stage, but not only tumor stage, but also the volume of disease. If you're looking at the high-risk CTV volume, a high-risk CTV volume of a mean of more than 35 cc's is definitely associated with poorer outcomes. The question is, if you use interstitial brachytherapy or more advanced techniques or better coverage, then do you get a better outcome because of that? The other factor that is important, and is not often looked at, is the overall treatment time. In some instances, downtime because of either patient toxicity or resources, and service delivery issues, which we face in lots of parts of Africa. Any prolongation of overall treatment time more than 50 days can result in significantly poorer outcomes as well. And so what about the elective nodal radiation? And I think this question was posed to the previous speaker. The EMBRACE group has published very good guidelines in terms of what to incorporate when in patients with localized cervical cancer for radical chemotherapy, chemoradiation. They divided into 3 risk groups, which is very nicely described. The low risk is the patient who has a tumor less than 4 centimeters, or patients with stage 1A or 1B1 or 2A disease, squamous cell histologies, and with this absence of uterine invasion. The intermediate is a patient who does not have low-risk features, but doesn't have high-risk features either. And high risk is defined as those patients who has one or more pathological lymph nodes at the level of the common iliacs or above that area, or more than 3 pathological lymph nodes in the pelvic area. And their recommendation is based on the data of follow-up in terms of failure sites, is to incorporate the para-aortic lymph nodes up to the renal hilum in patients who are defined as having high-risk disease. And this is because of the pattern of relapse that occurs long-term in these patients. Okay. One of the other important factors that has been found to influence both the outcome and the toxicity is the 43 gray planning target volume. And this data shows very nicely the results from the EMBRACE Part 1 and Part 2 studies. And looking at both pelvic and para-aortic radiation, and then looking at patients who were treated with IMRT versus conventional radiotherapy. And one can see that the 43 gray volume is definitely much better in patients who are receiving IMRT technique or based radiation, and where there's an attempt to reduce the 43 gray volume as it was in the EMBRACE 2 studies. These patients had basically less toxicities compared to those that had a larger 43 gray volume. So why am I bringing this up? I think if we are going to be looking at offering hypofractionated regimens. One of the things that we're going to be concerned about is acute and late toxicities. And one of the ways that we need to perhaps circumvent that is to find an equivalent 43 gray volume for whatever hyperfractionated treatment that is developed or studied, and try to restrict that in order to reduce the toxicities that we see even in conventional radiation schemes. So what about dose, fields, and chemotherapy? As I mentioned previously, concurrent cisplatin chemotherapy is a standard of care. Elective nodal radiotherapy is definitely now being almost a norm where it's possible, but it does require very complex planning techniques and does result in increased toxicity. Whether we can offset that by using volumetric arc or IMRT and by reducing the 45 gray volume remains to be seen. And furthermore, whether we can basically improve local control by paying attention to the gross nodal disease, which is outside the realm of the brachytherapy applicators, and will require some kind of boost dose in order to achieve better local controls. And there's all these factors we need to consider and incorporate into an hyperfractionated regimen before developing these regimens as such. The BED values are very important in terms of indicating the response to hyperfractionated radiotherapy. We do know that those disease entities or those tumors which have a low alpha beta ratio demonstrate high fractionation sensitivity. So the higher the dose of fraction, the more sensitive these diseases are. What about the BED value or the alpha beta ratio for cervix cancer? If you look at this study, which showed the different alpha beta ratios from different publications, the alpha beta ratio for cervix cancer is quite wide and generally above 10. If you look at rectum cancer, for example, it's more in the lower range, less than 10. Prostate is definitely below 10, probably below 8. Bladder cancer, on the other hand, seems to mimic more cervical cancer. And if hypofractionation seems to be quite effective and not more toxic in bladder cancer, then perhaps there's reasons to agree that it will actually work quite well in cervical cancer as well. So is there any gains that we're going to get from it? Because definitely the alpha beta ratio is not going to be the gain because it has higher alpha beta ratio and therefore doesn't demonstrate an increased sensitivity to changes in fractionation. But the gains will be in terms of the time factor. And that is basically incorporated with the total treatment duration, which we know in cervical cancer, if we aim to keep that below 50 days, we'll have an improved outcome. The TK, which is the time where accelerated repopulation kicks in. And for cervical cancer, this might be anything from 3 weeks, 21 days to 35 days. The potential tumor doubling time, which also can be quite variable, but usually less than a week. And also the alpha, which is basically the indication of the tumor radiosensitivity. And this can range from 0.1 gray to 1 or 0.5 gray to 1, depending whether the tumor is relatively radioresistant or radiosensitive, but bearing in mind that the tumor populations are not homogeneous and there can be heterogeneity in terms of radiosensitivity across the tumor. So you can see from looking at this that one of the gains of hypofractionation is that it will decrease the overall treatment time. And that decrease in total treatment time will then result in a better biological outcome based on the fact that your treatment is delivered in a shorter space of time. And this will offset the doubling from either the short doubling times or the radioresistance or from the time for accelerated repopulation. Okay. A recent study looked at the use of hypofractionated regimens in different parts of the world. And the bar graph on the extreme right for both for locally advanced and palliative symptom control is a reflection of the practice in Africa, those countries that took part in the study. And as you can see, hypofractionated regimens are preferred in the African continent compared to elsewhere in the world for locally advanced cancers, and definitely for palliative treatments of very advanced disease or metastatic disease. So the practice is there, despite the fact that there is limited data to support that particular avenue of treatment. And looking at what are the barriers that we may have to overcome, or what are the justifications for using hypofractionated regimen, I think the number one key driver in the African continent is resource optimization. This is the commonest cancer that we see, it's commonest in sub-Saharan Africa, and about a third of patients are HIV positive, and the majority of patients present with stage 3 disease. We, like many other centers in this country, see about maybe 20 new referrals that come through our department a week, even more sometimes. And most of them come with very advanced disease. and trying to optimize our resources because we don't have the staffing or the technology or the machinery to meet that demand is an important thing. And also many patients travel from very far. And so a shorter treatment protocol will be very attractive based on the fact that it will shorten the treatment at the time that the patient actually spends in hospital waiting or completion of their treatment. The barriers to utilization of hypofractionation includes the concerns about the lack of long-term data, the perception that there's inferior local control, and less so is the acute toxicity and the late toxicity. So I think that if we can actually have publications or studies that actually indicate that, that long-term control is the same, and there's long-term data is equivalent, and the toxicities are no dissimilar between the two regimens, then there will be definitely a lot of centers that will be practicing hypofractionated treatments for these patients. So what trials or what data or what evidence do we have to date about hypofractionated treatments? So in 2004, there was a Brazilian study which looked at 34 patients. It was a phase 1 and 2 study looking at about stage 3B patients. And this used an interesting protocol of 2.5 gray twice a day on days 1 and 3, 15 and 17, 45 and 47, and 59 and 61. So there was big breaks between the treatments. They used a simple 4 fields conformal. L5 to S1 was a superior border, and then gave low dose rate brachytherapy on day 29 with equivalent of 30 gray. Concurrent chemotherapy comprised cisplatinum at a lower dose, 15 milligrams per meter squared. But this was given daily for 3-day sessions to coincide with the treatment days itself. And this was combined with 5-FU 400 milligrams per meter squared. GI toxicity was basically present in the majority of patients, which about 32 of the 34 patients experienced some grade 1 toxicity from GIT. And there was a lot more nausea, but this might have been from the chemotherapy as well, and not too significant hematological toxicity. The 5-year overall survival was 59%, and most of the recurrences were in the pelvis, with some distant recurrences as well. There was a publication as an MA publication in South Africa looking at a retrospective review of 104 patients, stage 3 disease, given 40 gray in 16 fractions, together with brachytherapy, 18 gray in 2 fractions. I know many centers in South Africa prefer the 18 gray in 2 fractions, and the reason for that, it came from some data from India, which showed that this was actually well tolerated compared to the more prolonged fractionation schedules that are utilized. The patients were not given chemotherapy. Late GI toxicity was seen in 4 of the 104, and genitourinary toxicities were not documented in any of the patients. This was retrospective, and one of the challenges we do have is poor follow-up data, especially more than a year after treatment. Complete responses was documented in 70% of patients, and the disease-free survival that was calculated at about almost 2 years was 59%. There was a study from Nigeria which looked at patients prospectively at 480. Here, there was a hypofractionated regimen of 50 gray in 15 fractions versus a conventional treatment of 50 gray in 25 fractions, given together with LDL brachytherapy of 30 gray. Chemotherapy was not offered in these patients. The late toxicity for hypofractionated was 46%, and for conventional fractionation was about 12.8%. If you look at the 5-year survival rates, looking at stage, they include stage 1 to stage 4 patients. If you look at stage 1 for hypofractionated, it was 91% versus 92% for conventional. Stage 2 was 67% versus 69%. Stage 3 was 40% versus 42%, and stage 4 was basically 18% versus 19%. A prospective study in India involving 60 patients used 50 gray in 25 fractions with a lower dose, 42 gray in 15 fractions. Brachytherapy was high dose grade, given as 21 gray in 3 fractions, a slightly lower than usual cisplatinum dose of 35 milligrams per meter squared. They found the rate of proctitis to be 20% in the conventional arm versus 46% in patients who had brachytherapy, hypofractionated radiotherapy, and the cystitis rate was also significantly higher, but the gradings are not clear. The conventional fractionated treatment, the overall survival was, disease-free survival, was 67% in 1 year, and the hypofractionated was 60% in 1 year, so not too far apart. And similarly, another study, prospective design for 52% compared conventional fractionation versus hypofractionation. In this particular one, the dose fractionation was 39 gray in 3 fractions. The brachytherapy dose was slightly lower at 6 gray times 3 fractions, and a full dose of cisplatinum, 40 milligrams per meter squared weekly was utilized. The acute toxicity for nausea and vomiting was 15.3% in conventional versus 23% in hypofractionated. And the GI toxicity, when looking at grade 2 or 3, was 50% versus 57%. Complete responses were 73% in those with conventional treatments versus 69% with hypofractionated radiation. Another prospective study, also looking at about less than 100 patients, also looked at 39 gray in 13 fraction versus 15 25. Predominantly stage 3 patients using conventional fields and using high-dose rate brachytherapy. And this found that there was acute GIT toxicity was about 44%, which was about grade 3, and grade 4 toxicities, and acute GUT was about 21%. In about 13% of patients had late toxicity, of which there was rectal toxicity in about 27%. The disease-free survival and overall survival was about 59% and 50%. A study that was more recently published in 2 separate parts from Uganda. They initially publish the outcomes of the hyperfractionated and thereafter the differences between the HIV positive and negative group. This also looked at more stage 2B and 3B disease. More or less 50% on either side got conventional versus hypofractionation. The conventional dose there was 15-25. The hypofractionation was 14-15. Patients were treated with APPA, cobalt-60 to the pelvis. And 44% got cisplatinum weekly, 40 milligrams per meter squared. The grade toxicities were very similar between the 2 groups, and the overall survival was also similar between the 2 groups, and they did not find in the later publication a difference between HIV negative and HIV positive patients. There are many ongoing randomized studies at this moment in time as we speak. The results of these are not available as yet. Some of them are closing at the end of this year. This include the prospectively designed heroic study looking at patients with 1A to 2A and limited volumes 2B and 3C1 disease. For the hypofractionated, they're looking at giving 40 gray in 15 fractions and a high dose area of 48 gray in 15 fractions as their simultaneous integrated boost with concurrent cisplatinum. The highest study is looking at phase 1 and 2, looking at more advanced disease. And they're looking at giving hypofractionated at 2.67 times 15 with basically a nodal simultaneous integrated boost of 45 to 48 gray. The technique that's being used is MRT, and these patients are those that will be unsuitable for chemotherapy. A phase 2 study in Mexico, also looking at advanced disease, also looking at 45 in 25 versus 37.5 in 15 fractions. Planning will be with a 3D conformal technique, and the brachytherapy dose will be 28 gray. And once again, cisplatin will be given in this study to the full dose of 40 milligrams per meter squared. So we look forward to the outcomes of these particular data, especially the ones that are being conventionally planned, which is what most countries which have a high burden of cervical cancer have planning systems available for. Interestingly, there was a recent phase 1 and 2 study looking at endometrial cancer specifically, and this was in the adjuvant setting, where we know that toxicities are increased compared to patients who are not operated on or patients who are receiving definitive therapy. And they gave a dose fractionation of 30 gray in 5 fractions, weekly or alternate days, in a total of 61 patients. It was a phase 1 and 2 study, and they found there was acceptable grade 1 and 2 toxicities. And there's only one case in that limited number of 61 of grade 3 GIT toxicity. So really pushing the boundaries in terms of the dose to the pelvis area. But once again, this is a group that is high risk for GI toxicity, especially because they often have comorbidities and because they also post-operative as well. So what are the challenges with hyperfractionated radiotherapy? So the main thing is that it's not currently standard of care, but it is practiced in a large amount of countries in the developing world. And this is driven more by limited resources rather than clinical evidence. And I think the large number of patients and the advanced stage of disease is the key driver in these situations towards the use of hyperfractionated protocols. So one of the problems that we do have in places where cervical cancer is highest incident is the access to imaging. I work in a tertiary academic center, and MRI scans can take up to 2 months to obtain. At the moment, it's down. PET-CT scans can take up to 6 weeks. Diagnostic CT scan, we need to admit the patient to get one, or you just do it the first time you do it, it's in the planning. So most patients that we see are actually just staged with using chest X-ray and ultrasound, just the old FIGO style of doing it. Majority of patients will have advanced disease in any event, and pelvic nodal ratios should be very high because most of our patients present with stage 3B disease, which directly correlates with the risk of pelvic nodal disease. About a third to 40% of patients are HIV positive in our center. The Ugandan study suggested there was no risk of increased toxicity. Definitely studies with conventional radiation and chemoradiation in HIV positive patients does not seem to indicate that these patients do worse than HIV negative patients. We definitely have a larger volume of disease, and there's a lack of advanced radiotherapy technology or image-guided adaptive brachytherapy in centers which treat a high volume of cervical cancer. And how to achieve that, or how to implement that, or how to move forward with that in high volume centers where you're giving brachytherapy to 10, 15, even 20 patients a day is a huge limitation in terms of who you're going to actually prescribe that to. Nevertheless, even though there's limited data, it's a very attractive option, and a lot of us use it as a treatment option for patients. I think for us, it just kind of gives us a bit of breathing space in terms of treating these patients who you don't want to treat palliatively, but you want to basically try and treat as quickly as possible, bearing in mind that the constraints within your environment. So I think definitely one of the things I think this talk highlights is that we definitely need clinical trials, and we definitely need collaborations between different centers who have a diverse range of technology needs in order to basically test this on a wider scale so that we have the data that we need to implement this practice long term. I think that the fact that it's been used in other disease sites should actually make us more confident in terms of going forward with developing hyperfractionated research protocols. Thank you very much. And I hope I wasn't too fast there. Thanks.
Thank you, Dr. Shanaz. That was an amazing presentation. I think that just checking the chat to see if there's any questions. And I know that there's some questions in the Q&A, but I think some of these have already been there.
That's correct, Stephen. Those are from previous presentations.
Okay. Yeah, so as I mentioned, like some of these, I mean, these presentations will be available after the education event because I know especially Dr. Shanaz's presentation had a lot of information in it. And so I know people, would like to go back and then review some of the information that she had discussed. So I just have one question for you. I know you mentioned, the need for clinical trials and collaboration. So are there some active projects currently going on, or I know you had showed a few ongoing ones, but what do you see as some other, I guess, obstacles in having some clinical trials, started?
Yeah. I think for my center, and I think I speak for a lot of this continent, we have a highly migratory population, and we have people who live very far away from treatment centers. Some of our patients travel more than 400 kilometers to get to us, and we have to admit them during the duration of the treatment. And so one of the challenges we have with this is we need long-term data. We need to have survival data. We need to have long-term outcomes, and you need patients to come back for follow-up for that. And so if you have a patient who's living 400 kilometers away, in the African continent, it's very strange. One of the things we find is patients present advanced because until something really afflicts them physically, they're kind of willing to, their threshold for tolerance of symptoms is quite high. And so once they feel much better, they don't feel the need to come for follow-up. And so follow-up data is going to be a major challenge for us, I think. Trying to make sure that patients come back and documenting the fact that they have, no evidence of disease or they have progressive disease, etc. I think the second challenge for me personally, and I think for many other people, is accessibility to diagnostic imaging. I think for us, we have long waiting times to get access to that. Even something like a diagnostic CT scan or a PET CT scan, we have that available, but there's just so many patients that we're treating. I mean, we treat 3,000 new patients a year. And this is one of two big centers in the province, and the other treats even more, about 3,500. And so one of the challenges we have is that there's still so many patients, and about 50% of our patients are cervical cancer. So trying to establish quality control and trying to have the diagnostic imaging, which we're seeing is impacting on how you plan your treatment fields, etc., is a major challenge for us. So I think we need to somehow the other, when we have protocols, we follow what has been published in the Western world, but we don't actually, check that in our situation and see whether it's working or not. And I think one of the challenges we have is that we just don't have the resources to do that kind of research because of patient follow-ups, because of the restraints that we have in terms of, imaging. And also in terms of staff resources, we quite short-staffed. We have, busy oncology clinics, and it's very difficult to do that kind of research. But I think it's something we have to do, and I think we have to commit to it. And I think we have to look beyond the excuses and trying to find some way to do this kind of research, because I think it's going to have a significant impact in terms of how we practice and for the better, I think. Yeah.
So Dr. Shanaz, I know we have about maybe 10 minutes into the next presentation, but there are two questions in the Q&A at the very end. I think they are directed towards you.
Stephen, I wanted to follow up on a question from you, the comment,
Sure.
if I may. Since this is connected, I think it'll be important. So there are potential opportunities, I think, if global health catalyst and radiation knowledge, and if we are able to, facilitate in doing single institutional or multi-institutional clinical trial, maybe in different African countries. This is something that maybe offline, we can see how we can, speak with you and see how this can be. Are there potential opportunities for that?
That would be fantastic. Yeah, I think the question is related to the link for the.
It's at the very end. Questions.
Yeah, okay, sorry. Okay. And I said the struggle of low-income countries and the idea behind developing hyperfractionated cervix, from my humble experience, is going to be difficult to reproduce the prostate and rectum results. I think I agree with that, but I think what is heartening for me, when I looked at the prostate results, I found that, they were still using conventional treatments in some patients, in majority of like centers, and they were still able to get good results. And I think that in itself is indication that we shouldn't be kind of, thrown off by that. And we shouldn't try and, kind of replicate the outcomes in other centers. We should do what within our limitations and adjust a plan for that accordingly. So the other question is, are centers using concurrent chemo for hyperfractionated outside these trials? Our center practices, we do the 40 and 16 fractions. We don't give concurrent chemotherapy. Most of these patients that we treat with that is patients with advanced 3B with hydronephrosis. And often they might have, borderline impairment or soon going to impairment. And from my experience, we stay away from that because we just don't have the data for that as well. I'm not sure if anyone else out there who does.
There are two hands raised. I don't know if these are questions or. So I guess, Ahmad, I guess people with the hands raised are they have no they have no mic. Is that correct? Well, Dr. Abba, I see his hand raised also.
I think that they can ask questions directly in the chat box. So if they have any question, they can share it, and then we can discuss each question separately and will be answered by the speaker.
Okay, I think Dr. Abba, I think you have access to the microphone.
Sure.
Yeah.
Thank you so much for the presentation. It's quite extensive. However, just I have some scenario that is quite something that we commonly find. What will be your approach for a patient that have a para-aortic node that above the renal hilum with an hydronephrosis, not amendable for radical? Perhaps, even though we don't have evidence, is there perhaps any local protocol that you adopted to approach such patients?
Mm-hmm. Yeah, so we actually unfortunately treat those patients palliatively. So we generally use a dose of 8 gray to the pelvis, and we normally treat the areas of symptomatic disease. So if the pelvis is the one that's causing some predominant pain and bleeding and discharge, then we'll treat that. If the parotid lymph nodes are causing pain, we will treat that. So unfortunately, because of the resources, and often these patients don't present very well, they're actually in a very poor performance status. So my approach is generally to treat them palliatively, and we don't have the systemic chemotherapy that's available elsewhere to improve the outcomes in these patients. So our medical oncologists basically do not like giving chemotherapy to these patients because there's just so many, and we generally select the patients who have the better performance status or the better outcomes long term. So generally, I would basically treat them palliatively, and I would address the different sites, depending whether they're symptomatic or not. I think the ideal world, if the resources were available, you would stent the patient for the hydronephrosis on the side that's most affected. And then you would basically consider giving systemic therapy first, especially if there's very bulky or massive para-aortic lymph nodes, because it's very difficult to try and get a tumoricidal dose to that particular vicinity, and then assess for response. And if there's a response, then basically consider consolidating with radiotherapy. I think we have about 20% of patients treated in the private sector, and that's the approach we'll take if you have the resources available for that. But in the academic sector and the state sector that I work in, unfortunately, that palliative therapy seems to be the best option in that situation.
Sure. Thank you so much. So basically, in our center, we do nearly similar thing, but almost all of our para-aortic node, before reaching even becoming their peers to drop down, I treat them with an 30 grade to the para-aortic. And then the pelvics, I treat them reasonably 10 grade times 2 or 3, depending on how their response do. I do have the privilege of having a good communication or collaboration with the nuclear medicine department. So sometimes if it is below the renal hilum, I do a DMSA scan for the kidney, or either a renogram for the kidney to know which of the kidney I can preserve, and do a extended field, treat them radically. So I know there is a quite challenging in Gauteng, being medical oncology, and so it's quite different based on the environment. But it is something that if we can be able to have internal collaboration, it may really make a difference for us. Thank you.
Absolutely, absolutely.
There is a question that says, NCCN recommends radical treatment for stage 4A disease. How do you treat these patients at your center?
Okay, so I think not all stage 4 disease is 4A disease is the same. I think that, you have stage 4A disease where we have frank, rectovaginal and vesicovaginal fistulas, which present very advanced. These patients have very large volume, clinically palpable disease. And so those patients we definitely treat palliatively. I think then you have the patient who has stage 4A disease where, on further examination, either a proctoscopy and a colonoscopy or a cystoscopy indicates, or an MRI scan, if you're fortunate to have that, and that patient has basically involvement of the bladder and rectum through those means. Then once again there as well, we'll look at the volume of disease. So do they have extensive large tumors, more than 8 centimeters, going to the bilateral pelvic side wall, and is a hydronephrosis? And in that case, we would treat more palliatively. But you get the patient sometimes where there's more anterior infiltration rather than lateral infiltration, and has a small volume cervical tumor. Then I would consider treating those patients more curatively. One of the challenges is it's easy enough to get a diversion stoma if the patient is having an impending or possible rectovaginal fistula, but it's more difficult for us to get a Bricker's ileostomy or do a urinary diversion for patients who have basically bladder involvement. And so that makes it very, very challenging in that group of patients, because the quality of life is also an issue. So I think it's just not only about just being that particular stage, it's how is it staged and what is the volume of disease ultimately, and what's a PS that will help me decide whether I will just go completely palliative or whether I will go the radical route.
All right, thank you. So I think we will move on to our next speaker. Again, I would like to thank Dr. Shanaz for an excellent presentation, and hopefully you'll be able to be involved in our Q&A at the end of the session. Great.
Thank you. Thanks, everyone.
So our next speaker, Dr. Neil Tonk. Are you there, Neil? Oh, there you are.
Hi, Steve.
How you doing? Are you able to share your screen? Okay, great. So let me do a brief introduction for you. So Dr. Neil Tonk is an assistant professor of radiation oncology at the University of Pennsylvania. He leads the gynecological and brachytherapy service at UPenn, and is also director of imaging services. He completed his residency training at Memorial Sloan Kettering Cancer Center and the medical school and graduate school at Rutgers University, Robert Woods Johnson Medical School. His clinical interests in the treatment of gynecologic and breast cancers, brachytherapy, procedural radiation. His research interests lie in development of novel PET tracers, radionuclide therapies, and translational molecular imaging. He works with collaborators to develop innovative brachytherapy education tools that are low cost and can scale. And so Dr. Hawk would talk to us about how do you evaluate a good plan versus a bad plan. So it's all yours, Neil.
Great, thanks so much, Steve. Thank you again for inviting me to participate in this program. I've been listening to the lectures from earlier today, and I myself have been doing a tremendous amount of learning. I'll be discussing plan evaluation with some attention to issues and challenges in the treatment of cervix cancer. I hope that you take away some additional skills and that you implement them in your own practices going forward. These are my disclosures. So there are two fundamental rules of radiation therapy planning, in my opinion. The first is don't miss. So you must make sure that you treat what you intend to treat. And the second is don't hurt the patient. So if we can follow these rules to the best that we can in every capacity, I think we'll do a great job of treating patients. And we always want to strive to do a little bit better and a little bit better every single time. So number one, don't miss. Number two, don't hurt the patient. Plan evaluation is a core skill in clinical radiation oncology. It is tremendously important in every aspect of care. And I'm mostly going to speak from the physician perspective for the next few minutes. So a radiation oncologist is responsible for the delivery of safe and effective radiation in all aspects of their care. This is still understanding that every team member plays a critical role. For example, the medical physicist like Shibu will develop a treatment plan, and a radiation therapist like Dexter is responsible for delivering that plan in a high quality manner. But ultimately, the radiation oncologist is a team leader and is responsible for all aspects of the care. Plan evaluation can catch errors in decision-making, planning, and intent, and allows everyone to be able to catch these errors before they arrive to the patient. The radiation oncologist is a team leader that helps these other team members execute, and as well as motivating these team members to improve the quality of the care that they're delivering. And an unfortunate but very real admission is that toxicities will always happen. There is no non-toxic radiation therapy. They will all happen to some degree, but the goal is to reduce them as much as possible. And high quality plan evaluation can accomplish that. The world is becoming increasingly more complex, particularly radiation therapy treatment planning. So we'll keep it very simple to start. This is a summary slide of what we believe is the present and future of treatment plan quality in radiation. So there are a number of different tools, and this is mostly written from the treatment planning perspective of understanding challenges and applicability in dose metrics. So understanding how dose is delivered, how we quantify it, and what organs are receiving what dose. Plan robustness. So understanding how do we minimize and mitigate the uncertainties in radiation treatment planning. And then the complexities. So high complexity plans may be more robust, maybe less robust, I'm sorry, but require some more technical ability to overcome that. So these are aspects of technical treatment planning that are very important, that all go into what we describe as a high quality plan from the treatment planning perspective. But again, there are aspects that the physician is responsible for to make sure that they execute this in a high quality fashion. So how do we get started and improve in plan evaluation? Again, speaking from the physician perspective, you must understand every aspect of plan creation, including simulation, planning, and quality assurance. You don't have to be an expert in these areas, but you do have to understand how each one of these portions is executed. All plan evaluation must be approached systematically every single time. using specifically checklists. Checklists are high-quality methods to ensure that you are systematically reviewing and executing every task that you want to execute. Checklists are used in all aspects of care, as well as non-medical care. We know that surgeons use checklists to make sure they have all the tools available to them before they start a surgery. We know that airline pilots use checklists for every aspect of flying a plane. It's not practice makes perfect, it's perfect practice makes perfect. So when you're evaluating a plan, approach that plan deliberately, approach that plan systematically, and offer your best evaluation every single time, because perfect practice makes perfect. We want physicians, particularly trainees, to be active participants in their plan evaluation, asking questions, and then for trainees, leading the initial evaluation. I would get over the idea of potentially embarrassing yourself by giving a not great evaluation. That's the purpose of a training program. But if you give yourself opportunities to lead these evaluations, it will help out in the future. And then finally, understanding what you're looking for. So this is the idea of seeing the forest for the trees, which means that if you are not able to break it down into very specific things that you are wanting to look for, you'll miss the whole point. So we need to specifically look for target coverage goals and normal organ goals that we have in mind. So I'll start with external beam plan evaluation. We'll focus a lot of time on this system called CB-CHOP, which is a systematic way to evaluate plans. We spoke earlier about everything really should be reviewed with checklists in most every capacity. CB-CHOP is a method to systematically review plans every single time. It was first published, I believe, by Dean in Applied Radiation Oncology in 2017. This article is freely available online if you Google CB-CHOP. CB-CHOP consists of the following aspects, and we'll review each one of these individually. First step is reviewing your contours, making sure your target volumes and your organs at risk are correct. Next, selecting beam arrangements in fields that are logical, reasonable for what you want to do. Then evaluating coverage. This is the aspect of rule number 1, don't miss. Heterogeneity and hotspots, understanding what the heterogeneity is and where these hotspots are located. Your organs at risk, which is your number 2 rule, which is don't hurt the patient. Understanding that you're looking for constraints, corresponding isodose lines and DVH. And then the prescription. This is your last opportunity to check the prescription, including the total dose, dose per fraction, and image guidance before that patient is treated. We'll first start with contours. When you receive a plan that is completed by a dosimetrist or physicist, before you sign the plan, this is your last time to review the target contours. I encourage everyone to check their clinical target volumes, check the planning target volumes and the expansions that are used to reach those target volumes, and then check for any Boolean or cropping or summation errors. This is the last time that you'll have an opportunity to do that. It's important to review these target contours because these target contours are what you gave your physicist or dosimetrist to actually plan your radiation. So if there's an error in your target contour, you earned that error in your treatment plan. So this is your last opportunity to fix it, send it for revision before the patient is treated. And then for cervix cancer specifically, you want to check all of the normal organs. And this depends on if you're treating just the pelvis or pelvis and periortics, but at the absolute minimum, the rectum, the bladder, the bowel. We contour as a bowel bag, but some clinics will contour as small bowel, large bowel, and sigmoid colon. The duodenum, which is very important for treatment of the periortic nodes and is the most radiosensitive small bowel organ. The pelvic bones and femoral heads, the ovaries if you're trying to spare them or document the dose, as well as some other organs. For example, if you're treating the periortics, encouraged to contour the kidneys as well. So this is your last time to do that. The next is checking your beams. I also use B as an opportunity to check bolus. So first, understanding, are the beams logical to execute your intent? So if you're aiming to treat the whole pelvis with a 3D technique, are those beams able to treat the whole pelvis and minimize dose to other organs at risk? So for example, in cervix cancer and treatment to the whole pelvis, the beam arrangements are most often going to be APPA, 3-field, or 4-field. But if you see a 4-field box in a diamond shape, for example, an oblique pair, that's probably not appropriate. In addition, are the beams of the appropriate energy? In treatment of the pelvis, high energy beams are often needed and preferred, and we're not able to use 6 megavoltage or MV energy beams simply because the targets are quite deep. So if your facility has the appropriate energies, are you using the appropriate energies for that? For clinics that have access to IMRT and VMAT, in our clinic, if we're using static field IMRT, which we largely no longer use, it's a minimum of 7 beams that's required in the pelvis, or 2 full arcs for volumetric therapy. And a very nice tip is you do not shoot through the hardware. So you'd want to make sure that if a patient has a prosthetic hip or some other hardware, that you don't shoot through that. So B is beams and bolus, understanding, are they logical and are they appropriate? This is diving more specifically into 3D beams. This is a patient of ours that's treated with a 4-field box. The angles of the 4-field box are 0, 90, 180, and 270. So an AP, a left lateral, a PA, and a right lateral. And the goal is to encompass the uterocervix, vessels, and any gross nodes with a 1.5 to 2 centimeter margin. A traditional 4-field box is done with bony landmarks only, but a modern 4-field box is done through contouring the vessels, any gross nodes if present, the uterocervix, which is in purple here, and the bladder, rectum, and other OARs for documentation. And then you set your blocks or your MLCs. So this is an AP view of a 4-field box, and then this is a lateral view of the 4-field box in our preferred technique. Some opportunities to show the genitalia as well as the small bowel. So this is an example of logical beam placement for 3D fields. The C in CB CHOP is coverage. So you must review graphically if available, as well as the dose volume histogram of targets. And I encourage people to review them in axial, sagittal, and coronal planes. The goal for volumetric treatments is generally 95% of the volume receives 95% of the dose. We choose to do 97, 97. And we generally do not compromise target coverage for cervix cancer. We don't want to miss any part of that cancer. So within a 4-field box example, you want to make sure that your 100% or your 95% isodose line, which is outlined in green here, entirely covers your intended target of the whole pelvis, which it does here. For coverage for both IMRT or 3D plans, you'd like to see sharp target shoulders to get you that 95, 95. The way that this is read is that this is the absolute dose, and how much of that absolute dose is going to the relative volume of the structure. So in this example, the entire volume is receiving 45 gray, which is good. So you want sharp target shoulders if you're looking at the DVH, and you want, especially if you're doing IMRT, and for 3D fields, you want to make sure everything is covering everything. The next is heterogeneity, or the hotspot. The goal is to keep a relatively homogeneous plan and to minimize heterogeneity, which can be done by minimizing heterogeneity in IMRT or keeping your Dmax relatively low for 3D plans. Our goal is to keep the Dmax less than 110% for 3D and less than 107% for IMRT and VMAT. Hotspot should be in targets, but not in OARs. So in this example, this patient has a gross pelvic node. The hotspot is within the GTV of the pelvic node, so it's within the target. However, you could have a hotspot here, which would be in the small bowel. It is in the target, but it's also in an OAR. So hotspots are encouraged, if they're present, to be placed into targets and not into OARs. The next is to review organs at risk, also graphically and also from the dose volume histogram. Modern cervix constraints, like Dr. Shanaz was saying, are also available in the Embrace 2 protocol, which is freely available online. The most important ones for cervix cancer tend to be the bowel, the rectum, and the bladder. And again, sharp target, sharp corners for the PTV. Again, we always want to maximize, we do not compromise dose and coverage to the cervix and the target. But we do want to minimize as much as possible dose to organs at risk. These are our organs at risk constraints for squamous cell carcinoma of the cervix. This is using IMRT. These constraints were developed from the Embrace 2 protocol, and then they were further refined in our clinic when we saw what we can achieve. Again, the goal is for 97% of the volume to receive 97% of the dose, keeping this hotspot less than 107%, and minimizing dose as much as possible to the bag bowel, the rectum, bladder, the bony pelvis, the femoral heads, as well as the ovaries if they are possible to be saved. In addition, we try to keep the maximum dose to the rectum, bladder, and bowel relatively low because we want to spare those organs for brachytherapy. And finally, the prescription. This is the last opportunity to make sure that the prescription matches the plan. And this is your opportunity to ask the following questions. Did the planner make the prescription you asked for, specifically in regards to dose per fraction and number of fractions? Are you using the correct type of radiation, photon radiotherapy, electrons, protons? Are you using the correct technique that you intended to use, 3D versus IMRT versus VMAT? And is the radiation correctly scheduled? Do you want fractions that are delivered? How many fractions per week? Do you want them treated once or twice daily? So this is your, and finally, the correct type of image guidance if you have image guidance available. Daily imaging to bone, including KV or megavoltage imaging, or cone beam CT. So the prescription is your last opportunity to ensure that you are executing and delivering the plan that you have intended. So the goals of plan evaluation: are you creating a plan that is as you intended? Are you creating a plan that maximizes the therapeutic ratio? You want to maximize the tumor control and reduce dose to the organs at risk. And then are there opportunities to improve the plan further within reason? You could probably spend an unlimited amount of time optimizing your plan, but there will be only so much you can do to improve that plan. So these should be the goals that you are thinking of as you're reviewing plans. So again, CB-CHOP, this is a systematic checklist-based way to evaluate plans. First going through the contours, then beam arrangements or bolus, the coverage, heterogeneity and hotspots, organs at risk, as well as the prescription, which includes your total dose, dose per fraction, and image guidance. We'll move to brachytherapy. We'll touch on this somewhat briefly, and then Shibu and Amalio will discuss this at length some more, and we'll also talk about it in the QA session. So one philosophy of cervix cancer radiation is the only bad brachytherapy is no brachytherapy. And understanding there are going to be some patients that cannot receive brachytherapy, our goals are always to deliver it because we know that when done in a high quality fashion, it is safe and it is very, 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 very effective. There are very few things that can replace high quality brachytherapy for the curative treatment of cervix cancer. There are many different types of applicators in brachytherapy. Briefly, the ones that we use most commonly in our clinic are the ring and tandem. This is a rectal retractor that was discussed previously. We also have tandem and ovoids. We also are using the hybrid Vienna style applicator, which is commercially available. This allows the introduction of needles to cover more tumor. For interstitial brachytherapy, which we do in our center, we have the Syed applicator as well as the variant Kalana. This is the Electa Venezia applicator. This is a very dynamic, complex applicator that allows for lots of different scenarios, but it requires, I would indicate, a fair amount of training to learn how to use in a highly effective manner. So brachytherapy must be effective and safe. You can create brachytherapy plans that are safe without being effective. That is not good. You can create brachytherapy plans that are effective and are not safe. That is also not good. This is an example from 2012, a plan from Dr. Keela Viswanathan's clinic, where a standard point A loaded plan is likely to, this could be a safe plan. However, the target volume as intended is outlined in this dashed line. Adding some additional needles can allow the 100% isodose line to curve out a little bit more, covering more of this tumor. you can see that the dose is still limited at point A, but then adding additional needles can really cover everything that you need, and the dose is more than it is at point A. So brachytherapy should be safe and effective. It can be one without the other, but that's not ideal. In traditional brachytherapy treatment planning, you would treat to point A, which is 2 centimeters superior to cervical os and lateral from the applicator, and is defined relative to the applicator. It was defined because it was found to be a dose-limiting point. So starting at point A is a fine place to start. However, customizing the dose within the applicator is very, very, very important to create both a safe plan as well as a highly effective plan. This is an example that was effective, but we wanted to make it safe and effective. This is a 30-year-old woman who was treated in our clinic with a 3C2 squamous cell cancer of the cervix. In this para-axial view, the target is in blue, the 150% isodose line is in peach, and the 100% isodose line is in red. Organs on this slide include the bladder, the small bowel, and the sigmoid colon. We can see that a lot of the 100% dose goes unnecessarily into all of these organs, the bowel, the sigmoid colon. In the paracoronal view, we can see that the target is relatively small to where point A is, and you can see 100% isodose lines going into various organs as well as above the uterine fundus, and similar on the parasagittal view. So this is a very effective plan because plenty of radiation dose will go to the cervix, but is not necessarily a safe plan. So we customize and modify the dose, particularly with 3D planning, and we are able to keep a lot of the high dose radiation out of the organs at risk. We are able to safely and comfortably treat the high risk CTV or the entire cervix while reducing the dose to the organs at risk. And this patient has had no significant high grade toxicity since completing therapy. Our goals are to prescribe radiation with brachytherapy to the high risk CTV, which is defined as the cervix, any residual disease, and intermediate areas where you're not sure if it's cancer or not. You're obliged and obligated to just treat it. Our preferred dose fractionation is 7 gray times 4. We do this in 2 insertions. We normalize to point A, and then we customize the dose. Our minimum preferred dose to the high-risk CTV is 85 gray. For adenocarcinoma of the cervix, our minimum preferred dose is 95 gray. We always try to keep the maximum dose generally under 100 gray, simply because it would increase the dose to the organs at risk. Our preferred dose limitations for the EQD2 dose to the 2 cubic centimeters is 80 gray for bladder, 65 gray for rectum, and 70 gray from sigmoid. These are also from the EMBRACE2 protocol. And when OARs are limiting treating large or asymmetric HRTs, CTDs, we'll switch to an interstitial implant. So Shibu will discuss this more at length in terms of equivalent dose calculation, but there are free sheets available on the American Brachytherapy website where you input the dose per fraction and then and the total dose, and then you can get dose to the tumor as well as normal organs. Let's see if this works. Does not work. Okay. If you're still able to see the sheet, this is a dynamic sheet that is inputted where you type in the total dose per fraction and the number of fractions. And then you can say, for example, input the bladder dose, which is say 8 gray per fraction times 4 fractions, which would very well exceed our bladder targets. This is 113, and we'd want to reduce that to 80 gray. So this is an example of how these sheets are used, and they are very, very, very important for dose documentation. This is the Vienna hybrid applicator where the plastic ring cap is replaced with additional interstitial needles. This allows treatment of large volumes greater than 30 cubic centimeters very effectively. This is again an example of an asymmetric HRCTV. With the addition of additional needles, you can increase the coverage. So circling back to that example in the beginning, hybrid applicators do allow for this increased therapeutic ratio. They're very beneficial for large targets. However, they do come with the increased risk of bleeding, and there is an increased need for training. Thank you for your attention. I will stop sharing my screen. I welcome any questions or comments or discussion. Thank you all.
Thanks, Neil. Thanks. Great talk. I think I did see one question here. It says, in DVH is showing bladder received between a B40 to 20% only. Is 3D in 3D? How is it achieved?
Okay, so the question seems to be understanding that we're hoping for very low doses to the bladder. Sometimes this is not possible with 3D planning, because in the spirit of making sure you do not miss the cervix, you have to potentially give more radiation than you want to the bladder and the rectum. For 3D plans, oftentimes the bladder is entirely covered or the rectum is nearly entirely covered by the 3D plan, and that is very challenging. So with IMRT, these lower doses are achievable, but with 3D it's not. And if you're using APPA planning, it is impossible to spare the bladder and the rectum from radiation. If you do your best to stick to around 45 gray and then deliver your maximal dose with your brachytherapy, especially a 3D planning, that can be another way in which you can spare the bladder and the rectum from radiation.
I think another question, he said, do you have anything to verify the brachy plan before treatment? Do you have any advice?
Okay, thank you, Khan, for the question. So we will discuss a little bit more in the quality assurance discussion that Shibu and I will be doing. It is important to immobilize the brachytherapy applicator in between implantation and treatment, because patient transfers and patient movement can dislodge the applicator and then and change what you are delivering. And that's, of course, very bad. There are different methods that can be used to immobilize the applicator, including stretch net stockings, clamps, or other immobilizing devices. In terms of verifying before treatment, we do a 3D image before treatment. For example, if the patient is admitted overnight with the applicator in place, we'll do a CT in the morning to verify treatment and then go to treat. Some other clinics will verify with a 2D image or a fluoroscopy image to verify that it is in the correct place to treat. So there are lots of different methods to increase your confidence that you are treating with brachytherapy as intended.
There's another question in chat. I don't know if you can see it.
Yeah, could you please show the beam arrangement 3D CRT for cervix cancer? Habir from Iraq. I will reshare my screen in the last couple of minutes we have left. The beam arrangement is very simple. It is what we call a 4-field box, and it is a AP beam, a PA beam, a left lateral, and a right lateral. So there are 4 beams coming in, all at right angles to each other at 0, 90, 180, and 270 degrees. This is an AP example. The lower border is generally below the obturator foramens for cervix cancer, 1.5 to 2 centimeters margin around the vessels and nodes. Some physicians will treat to L5S1, some will treat to L4, L5. And then the lateral aspect of the beam, some physicians, again, will treat the entire sacrum, which is my preference. Some physicians will take the beam up to S1, S2, S3, and then block behind it. The borders for the sup and inf are the same, and then you are blocking some small bowel here as well as some genitalia here.
Yeah, see, questions are coming in now. What is your view about 2 fraction per day using 6-hour gap?
Okay. Yeah, so absolutely. So yeah, from Samuel asked about 2 fractions per day. We do that frequently for our interstitial brachytherapy and for patients, especially during the COVID crisis at its peak, when we were doing implantations in a single implant. We would treat with slightly lower dose per fraction, but we would deliver 2 fractions per day. Generally, we limit to up to 6 gray per fraction. Another comment from Nalima: for a better plan, we go with point A based plans or optimized plan for brachytherapy. I agree with you. We generally will start with point A and then we will further optimize. Nalima also writes, is this a field and field 3 plan? The example that I showed you is not specifically a field and field plan. We use a method called electronic compensation, which allows for some modulated fluence across the plan, but a 3D field and field plan can be used to improve your homogeneity. For example, if you have hotspots greater than 110%, you can add a segment to reduce your hotspot. CV chop is great. And then Khan also writes, could you share any standard dwell time patterns for brachyplan, cervix, ring, and tandem, which is better satisfying? Our preference is for ring and tandem. In general, if you had to pick, ring and tandem offers a superior therapeutic ratio. However, it is very nice to have ovoids available for patients with small anatomies. For standard dwell times, we can email you some opportunities, but there are many treatment planning and physics planning guidelines available from the IAEA about commissioning and starting a cervix brachytherapy program, including dwells.
Okay. So I think we should probably go on to the next speaker. But Neil, there are a couple questions in the Q&A that maybe you could look at, and if you could participate in the Q&A at the end, that would be great.
Absolutely.
So our next speaker, Shibu, are you able to share your screen?
Yes, I am able to. Let me try.
Okay. All right. That's good. So,
can you see my screen?
Oh, yep. Shibu Analeo. Hope I'm saying that correct. The senior medical physicist and chief of brachytherapy program in the Department of Radiation Oncology at the University of Pennsylvania. He also serves as the associate director of the medical physics residency program, which is the largest residency program in the United States. He completed his residency in radiation oncology physics at Thomas Jefferson University Hospital. He is certified by the American Board of Radiology and Therapeutic Radiologic Physics. He is also certified medical dosimetrist. His clinical responsibilities include proton therapy, photon therapy, and brachytherapy. And so now we're hearing a physicist's point of view. And so Shibu, the floor is yours. Thank you.
Thank you. As Dr. Avery mentioned, my name is Shibu Anamalil. And first of all, I am going to introduce Dexter. You already heard from Dexter. Dexter will be giving a short session about the treatment delivery standpoint from the therapy side, then I will take over from the physics standpoint. So you already heard from Dexter. Dexter will be joining first. Dexter, when are you ready? I am going to share your slides.
Okay, I'm ready. Can you hear me?
Yep.
All right.
That's first slide.
So in beginning treatment delivery, external beam radiation, like Dr. Tonk mentioned in his talk, one of the most critical things is a checklist. It allows you to be consistent, and it allows you to achieve all the points that's necessary for delivery of a successful treatment. We begin once the treatment planning is completed, and we put the patient's treatment plan into what's called treatment approved. So the plan goes from unplanned to planning approved to treatment approved. Once it's treatment approved, we have the patient come in, establish the first day, and on the first day we designate it as a simple simulation, because the original simulation was the complex simulation where you start from nothing and establish your treatment fields. And once those fields are established, we have a simple simulation. So we bring the patient in on the first day, they'll have a simple simulation, and then we'll deliver treatment. Before the patient arrives, we'll go through a checklist, and following is an example of the checklist that we have. Next slide, Shibu. It's pretty extensive, and it touches on all the things that are critical to identify that all the points have been achieved that's necessary for the treatment. We ensure we have identification identification information, the name, the various plans that are prescribed by the physician, and all the checks and points that the physicists and the symmetrists needs to put in to begin treatment. And there's a portion that we complete before the patient arrives, and there's a portion that we complete after the patient have been treated, just to ensure that everything is, and we developed this checklist over the years at Penn. Next slide. So we bring the patient into the treatment room. We identify the areas that was marked in the CT scan, so where we had the tattoos or the different marks that we placed on the patient for positioning. We identify the different devices that we use for patient immobilization and positioning, and we identify them on the patient, and we compare them to pictures that we've taken on the first day of simulation, to establish a consistent, reproducible setup and immobilization of the patient. Next slide. Here's an example of those marks being and the positioning being established on the CT scan. This is with the patient's arm up above their head, well away from the area of interest. And in the center of the upper right-hand corner, the center picture, there's a tattoo mark. And on the day of treatment, we highlight it with a marker, just because we treat the patient with the lights dim to be sure that we can see the treatment field projected on the patient's skin. We achieve reproducibility of positioning by what we call index bars on the lower left corner here, and the devices we use have different markings and different areas in which we can position them, record the position, and reproduce it from simulation to treatment. The next slide, Shibu. Once the correct treatment position is achieved, we begin by scanning the patient. We'll begin with a 2D imaging using KV imaging. We'll take an anterior and a lateral image of the patient, and on the treatment machine, we'll overlap those images with an anterior and lateral image from CT scan that was generated by the dosimetrist. And in overlapping those, we can compare bony structures and reposition the patient using remote movement on the treatment table to sort of get the patient back into position. If we identify that in aligning the images from the treatment position to the CT position is, out of tolerance, it takes large movements to establish those positions, then that indicates that something's not correct. So anything over a 2.5, 3 cm movement to get the patient in the correct position, that something's wrong. The patient, there should only be necessary to move millimeters to get the patient realigned into the CT position that was established on the first day. So then we'll go back in and reassess where we position the patient. If the patient had previous radiation in an adjacent area, we may be aligned to the incorrect tattoos, and things like that can be established. Next slide, please. We have within the checklist, instructions of how we assess on a daily basis the area to be treated. So the physician will put in instructions to use kV orthovoltage imaging, or doing what's called a cone beam CT, using the treatment machine to take a CT scan, and that will indicate whether the protocol for treatment is with a full bladder or an empty bladder, and we can use that cone beam CT to establish whether the patients adequately filled their bladder or adequately emptied their bladder. If there's an issue with excessive bladder filling, using the CT scan before treatment's delivered, we're able to correct for that and deliver a more accurate treatment. Next slide, please. Here's an example of the KV imaging. And so on the left, we have the KV images from the CT scan that was generated by the dosimetry during the planning. And on the right, we have the KV imaging taken on a treatment table. And we can see by the crosshairs that the position is relatively the same, within millimeters. And we have the opportunity to shift the table to correct for those discrepancies, vertically, superiorly, inferiorly, laterally, and there's some degree of rotation also permissible on the treatment table. Next slide, please. And here's an example of a CT scan. On the left this time, we have a CT, a cone beam CT from the treatment machine, and on the right we have a CT scan from the original planning CT. And using certain contours, you can see there's a little bit more bladder filling on the cone beam CT, but within tolerance. You can see the contour of the body, which is an indicator that the internal structures is a little displaced from where it was on CT, but we have a very good alignment of the femoral heads and other areas of the patient anatomy. You also see that there's a little excessive material in the rectum, which is distorting the treatment volume a bit. And this is where we have opportunity to change that. The main goal in achieving treatment is reproducibility and the ability to effectively deliver the treatment to the areas that it's planned to be delivered. And one of the greatest asset you have is identifying with pictures and then double checking with the checklist that Dr. Tonk mentioned in his talk, and using that as a guideline and apply it to every patient as exactly as possible. And I think that's the gist of the treatment portion. Okay, Shibu.
Yes, thank you, Dexter. And I will be briefly touching the external beam, and then I will cover some of the brachytherapy part of the treatment delivery in my talk. So as you hear from different speakers, like we don't usually do hypofractionated therapy for external beam treatment. And usually for these patients, the external beam dose is 45 gray. It's a 1.8 gray per fraction for 25 fractions, followed by brachytherapy. Brachytherapy treatment can be with intercavitary applicators like Tandem ring or Tandem ovoid. And in our institution, we use the 7 gray times 4 fraction fractionation. There are some other fractionations available around, but this is the fractionation that we use in our institution. And if the patients have a lateral extension, you can use a hybrid applicator. And for larger lesions or lower vaginal involvement, you will use interstitial. We'll switch to interstitial applicator. The 2 applicators that we use in our clinic I mentioned here. There are different other applicators also available in the market, like Dr. Tong mentioned, Valencia or MAC applicator and other applicators. So for external beam, the typical treatment is done using a 4-field box. This was already mentioned. There are 4 fields, 2 lateral fields and a posterior and anterior field. And as compared to the 3-field and a 2-field, definitely the dose is more homogeneous. Rarely for some patients, if there is, we need to consider the bowel sparing or part of the bladder, we can treat with the 3-field. If you just decide to treat with the 3-field, it's usually a posterior field and 2 lateral fields. The posterior field usually we use like a lower energy beams, and because of the wider separation, the lateral beams use high energy beams. For 2 fields, for some patients, for example, for a patients have a hip replacement, or patients have prior treatment to the hip. For some reasons, we need to spare any of the lateral side, we can barely treat an APPA field. That's usually for more like a palliative regimen. And in the modern era, most of the time we are treating with the VMAT or IMRT. If it's a VMAT, we will be treating with the usually 2 arcs, or sometimes some patients might need a 4 arcs. And for IMRT, we rarely use IMRT nowadays. Typically use 7 fields. For VMAT, if the patients need you can see the dose is conformed very well to the target. And also, if you need to do any simultaneous integrated boost to the node, you can do using this technique. And for treatment imaging, Dexter already mentioned this. For 3D plans, usually you can use daily SST check or daily KV imaging and match to the bony anatomy. And for some cases, you can do daily or weekly CBCT depending on the need. Some patients, we are concerned about the bladder filling or rectal filling, or any SST difference due to weight loss and gain, or any bowel dose concern. And if the patient is getting a nodal boost, then that's also typically that patients might get a daily CBCT. And for hyperfractionated treatments, typically we do a physics check right after the first fraction. We'll make sure this check is done before the second fraction of the treatment. This check usually includes most the physics initial chart checks, and that all the checks that we performed in the initial chart checks, plus making sure all the documentation is complete. And check again the dose and fractionation agrees. The main goal of this check is make sure the treatment was performed according to the treatment instruction and the imaging was performed according to the imaging instruction. And make sure from treatment side, the imaging matching was performed correctly. Also check where SST was checked, if there is any difference or it's documented and it agrees with the plan. And make sure all the beams are delivered and all the beams total delivered dose is correct. And if there is any discrepancy in the tracking of the dose. And this check will make sure all accessories included in the treatment, like a patient has a bolus or any wedge or block or compensators, which we don't use that often. And it's now with the automated field, this will be checked automatically, but you'll check that as well. Sometimes the physician may request for an in vivo measurement. So we make sure that's checked. That measurement was done. If it's not done, we can make sure that's done on the next fraction. So any change in the anatomy from simulation, or if any other concerns, you need to bring it up to the physician, like a bladder filling or rectal filling or any SST difference. You can also check during that first check. Now I will quickly move to the brachytherapy section. For brachytherapy section, we already, Dr. Tong and many other speakers mentioned about the different applicators. I'm covering the applicators that we use in our clinic. For intercavitary, we use the tandem and ovoid and tandem and ring applicators. And you can see the typical pear-shaped dose distribution from these intercavitary applicators. And for patients with the lateral extension, we can use a hybrid applicator. This is the applicator that we use. It's a Vienna hybrid applicator. This one has the titanium ring end applicator cap. We remove the cap and put a new cap in, which has 9 holes for the placement of the needles. And usually, typically, we don't need to use all these holes. We may use 1 or 2 interstitial needles on both sides. That will be sufficient enough to get the target coverage. And the bottom picture shows how nicely we can confirm the dose based on the need using this applicator. And for patients with even larger lesion or lower vaginal involvement, we switch to the interstitial applicator. These are the 2 applicators that we use for treatment in our clinic. And there are, as you heard, there are multiple applicators available on the market. The first one is a SIA template, which is a plastic template and plastic needles. This is a single-use applicator. The other one on the right side is a Kelowna applicator, which you can see this one is a reusable applicator with titanium needles, and the needles can be locked to the holes. That's the locking collet is showed here. For SIA templates, usually we glue the needles to the template. And you can see how nicely we can cover the wider targets using the interstitial treatments. And we also use the cervical probes. These cervical probes comes in 3 different lengths, 4 cm, 6 cm, and 8 cm, and at 3 different angles. The probes can fit into the stump cylinder, or it can be used for the cylinder that goes on the center of the Kelowna template, that the obturator, which is used as the obturator. So the Kelowna template, you can, for favorable patients, we can use this cervical probes with the center tandem, which is usually a 2.5 cm cylinder, and the interstitial needles. Then for treatment imaging for the brachytherapy, typically the patients get a daily CT. The plan is performed on the CT, and these patients get an MR also. In our clinic, our workflow is patient get a CT first, and then we will move the patients to the MR, and an MR sim will occur. At the same time, we will try to start contouring of the OARs on the CT while waiting for the MR, and start the planning from the physics side. And on the day, typically we treat 2 fractions with 1 implant. And for the second day, the patients get a CT in the morning, and we will register the CT with the planning CT. And if any movements we noticed or any concern for needle positions, we will replan the case. And that patient sometimes get the MR again, or sometimes we decide not to if the MR is not necessary. Mainly, we are looking for the applicator positions. Sometimes the applicator can be dislodged, especially for TNRs and TNO, the tandem and ovoid applicators, and check for the needle positions and any anatomical changes or AR changes. These are the things we are looking in the plan, and we copy the plan over to the new CT after registration and evaluate the OARs and doses. And in addition to the imaging, we do a manual verification using a physical measurement as well. I will go over more that later. And then after the plan is ready, usually we do a physics check, and that check is done by an independent check performed by a second physicist. They will make sure all the simulation documentation, any patient questionnaire, like if the patient had any prior radiation, any patient has any pacemaker, is the pacemaker patient is compatible for MR sim, make sure all this is checked before. And if the physician has any special consult request, for the patient who have multiple courses of prior treatment, things like that. And make sure the written directive is approved and agrees with the plan. And after, make sure the physician reviewed the plan, approved the plan. Then the physicists will complete their checks. Usually the second physicist will check the registration, contouring, contours, digitization of the applicator, dose, fractionation dose, and dwell time. Usually we look for any heavily weighted dwells, things like that. And we use a second check using a second software and make sure all these documentations are complete, and then the physics will approve the plan. Then the planning physicist will be the physicist responsible for the treatment. The physicists who did the second check usually export the treatment plan to the treatment console. Our workflow is we will do a DICOM export of the plan to the console, and that's how we export the plan to the treatment. And for treatment delivery, make sure all the routine QAs are done. I'm not going to cover all the details of the QAs. Make sure the equipment, all the equipment QAs, safeties, source activity, source position, survey meter, radiation warning lights, and all other necessary checks that's necessary for the safe treatment for the patient. Then the treatment physicist will make sure that plan transfer to the console computer was correct. There is nothing corrupted during the transfer. Also make sure the source is usually decaying is happening at the console computer. The plan is usually in our planning system, the plan is done for 10 Curie. And based on the source activity on that day, this is scaled at the console computer. So we'll make sure that's correct, and the written directive and dose again check, and then make sure all the treatment plan documentation and the second check documentation is in place. And then if the patient had any prior treatment, prior fractions for brachytherapy treatment, we make sure that's complete and nothing is missing from that treatment as well. Then for channel connections and other checks, usually we will go inside the room with the physicist and the therapist together. We'll make sure the connect transfer tube to the applicator and the afterloader. And we have a numbering template that for interstitial cases, we have a template that we created at SIM. So we have a baseline from the SIM, how much of each applicator or needle is protruding outside the template. So we have a baseline measurement, and every fractions we will check that again. And make sure the connect transfer tube and right transfer tube, because the different applicators uses different transfer tube. Make sure the right applicator transfer tube is used and connect to the right channel number. And since we have a gamma med IX system, the total length from the of the applicator and the transfer tube is usually 130 cm length. So we make sure with the guidelet tube that the total length matches. Then do the pre-treatment radiation survey, and then come outside, close the room, and then do a timeout procedure. The entire team will do a timeout procedure and deliver the treatment. And after the treatment is complete, go inside and do the normal post-treatment radiation survey and disconnect all the transfer tubes. Make sure all the doses are delivered completely and the dose tracking is correct, and make sure the treatment documentation is complete. Then if any weekly check needed, but for brachytherapy, since it's a high dose fractionation, we do the weekly on the first fraction as well. Then if it's the last treatment, we do an end of treatment as well. And this is my final last slide, which is showing the treatment schedule in our clinic. For tandem and ovoid, tandem and ring, or hybrid applicators, we do 2 fractions in a week, 1 implant, 2 treatments. Day 1, the patient gets a CT and MR-based planning. MR is usually for delineating the target. And day 2, CT verification and registration of the CT to the planning CT and decide MR needed based on registration results. And for interstitials, it's a 5-fraction treatment in single implant that happens in 3 days. For day 1, same as the intercavitary applicator, CT and MR planning, then afternoon treatment. Day 2, CT registration. If needed, we will do the MR and replan the case and do 2 treatments on that day in the morning and afternoon, with the 6 hours apart. And same on day 3 is the same as day 2. And after the treatment is done, the application removal after the last treatment in the afternoon. I think that's my last slide. Thank you very much.
Thank you, Shibu. It's a great presentation. I'm just checking the questions to see if there's any physics-related questions here. Someone asked something about the care path. I know it is your care path, but do we really need to put the patient at the sim first before the setup in the treatment room? I don't know if that's for you or Dexter.
We do have a care path for planning. And let me see the question.
Yeah, it's from Salim. 1148. It's in the chat.
Okay. Chat. And 48 in chat. I'm not seeing that chat.
Okay.
It's not in the Q&A session, right? It's in the chat.
No, it's in the chat. Yeah.
For your plan discussion.
Yes, yes. Well, I mean, I guess we can probably move on to. I know you and Neil have your session for management, quality management issues, and then we can probably come back to this for the Q&A.
If you can read the question, I can try to answer. I am not seeing that question now.
Okay, maybe I'll copy it and
I know it's your care. Oh, I know it is your care path, but do we really need to put the patient at the sim first before the setup in the treatment room?
I think he's
simple sim setup, right? That's the confusion.
I think he may be referring to what I mentioned as a sim. It's not. We don't take the patient back to CT. We do it right on the treatment machine. Yes. Term it as a simple sim because it's the very first state.
Correct. So it's the setup in the treatment room. It's not we are taking the patient back to the CT. The first day setup is called a simple sim setup. That was the confusion. Yep.
I know there's a question about prostate. I mean, I guess I would ask the participant, next week we have a session dedicated to prostate. So I would ask if they could, we can address that question for the speakers next week, if that's okay. Someone did ask a question, how many beams are used for 3D conformal 60 gray 20 fractions? It just came into the chat.
For 3D, usually the typical it's a 4-field box, right? 4 fields.
Okay. I think Neil did answer that question. One also had a question about beam arrangement for 3D conformal.
Yes, correct. Usually it's a 4-field technique. It's an AP and a lateral field, AP, PA, and 2 lateral fields. And very rarely, like I mentioned, sometimes we may come up with a 3-field or a 2-field. The 2-field is usually for palliative regimen.
The 60 gray and 20 fractions question may be better for the prostate session, because it's a more appropriate prostate dose. 60 gray and 20 fractions is not used for generally in treatment of cervix cancer.
Okay. Thank you, Neil.
All right, so why don't we just go into the next session, and then I just ask for the for our Q&A panel discussion, if all of the participants could just turn their cameras on, so that we can have everyone set up like in a panel format. when we do the panel session. But we can go into the next session with you, Shibu, and Neil to discuss the quality management issues, clinical versus physics point of view.
Great. Shibu and I have some combined slides. I will share my screen first, and then Shibu, if you want to share your screen, you could advance your own slides for that deck that we have. All right, thank you again, everybody, for your attention and interest in this course. Shibu and I have a combined discussion over the next few minutes about quality management issues in clinical radiation oncology. I'll focus on mostly the clinical aspects of it, and then Shibu will discuss some physics aspects of it as well. So we'll discuss external beam as well as brachytherapy. Quality means a lot of things. There's quality in the treatment plan, but quality is also taking care of the entire patient. External beam radiotherapy, particularly with chemotherapy for the treatment of women with cervix cancer, is very difficult treatment. Patients will need lots of support to complete their treatment, and it makes sense for really every clinic to do their best to offer support to these patients to make sure that they can complete their treatment. There are many side effects due to external beam radiation therapy to the pelvis, including weight loss, weight changes, and there's also rectum, bladder, and bowel changes. So we do our best to give support to patients with hydration, nutrition advice, and transportation to make sure that they can get to treatment. So I believe that's also a part of quality. Chemoradiotherapy is difficult treatment. It is daily treatment for 5 weeks. The chemotherapy is every week, and those chemotherapy visits can be long, and there are plenty of side effects to chemotherapy. So we make sure to offer patients discussion and counseling in regards to hydration, bowel movements, and dietary changes. The EMBRACE-2 investigators have created a goal that they believe that 80% of women should be able to complete 5 cycles of cisplatin. And this is an ideal goal, understanding that there are some patients that are ineligible to receive cisplatin therapy, and there are some patients that will not be able to receive any chemotherapy, but 80% to receive at least 5 cycles of the cisplatin. And another goal is for 80% of patients to finish treatment in less than 50 days. It is important to keep on time for treatment of women with cervix cancer because extending out treatment leads to poor outcomes. So this is also a measure of quality. There are many potential problems during external beam radiotherapy, including one aspect, and we'll talk about several, is tumor regression. Generally, tumor regression is not an issue for 3D plans. You have plenty of margin around tumors to cover everything, and even if the tumor shrinks, all of those normal organs are receiving plenty of radiation dose anyway. However, it may be a significant issue for IMRT, where the shape of the pelvis and the location of these OARs may change due to this. This is an older study that assessed the impact of tumor regression with radiation therapy. It's 14 patients. They had a every week MRI, and after 30 gray, so 2/3 of the treatment, the primary tumor volume decreased by about half. Some patients had 100% reduction, some had minimal reduction. And then replanning the patient with IMRT could significantly reduce the small bowel dose if the regression was more than 30 cubic centimeters. So if you have some measurable degree of regression, replanning the patient may help significantly reduce the small bowel dose, which is very nice. There's also problems of bowel gas and rectal filling. The biggest issues in terms of central pelvis motion are due to differences in rectal filling and bladder filling. So we treat with full bladder to better protect the small bowel. So inflating, having the bladder comfortably full, like how Dexter tries to get his patients, will allow the bladder to push the intestines up and out of the way, particularly the small bowel. And we also aim to treat with an empty rectum. This is an example of a simulation scan where this patient had lots of gas in the rectum, and we are obligated to treat more of this because this rectum may be empty during treatment, and then the vaginal target will go posterior. This is an example of the significant amount of motion moving the cervix and the vagina. Red is bladder, purple is rectum, and blue is the vaginal target. And you can see that there are significant differences of the position of the vaginal target depending on the rectum and the bladder filling every day. So bowel gas and rectal filling are problems. They are less issues with 3D radiation, but they are potentially significant issues with IMRT. We treat with, again, full bladder to protect the small bowel, and we treat with an empty rectum because that is the most reproducible. This is an example of a patient's uterocervix motion with and without different rectal fillings and bladder fillings. So we create an ITV with the two different types of bladders. And you can see that this is the patient's uterocervix on a cone beam CT, and even accounting for all of that motion, this patient's cervix target nearly fell out of the PTV. So there are significant motions that you must account for when you're doing highly conformal therapy. There are also weight changes and abdominal shape changes. Weight changes are significant because patients may experience significant diarrhea during treatment, and abdominal changes may be due to differences in bowel gas as well as weight changes. So we weigh patients every week to monitor for significant weight loss, and we consider robust beam entry, which is we try to use multiple beams to ensure that significant weight changes do not affect the quality of the radiation plan. This is going to be very meaningful for IMRT treatments, potentially less for 3D treatments, but you can see that, again, just with bowel gas changes, there are potentially significant changes from the planned anterior abdominal wall to the current anterior abdominal wall. So there are significant issues in regards to that. A handful of comments about brachytherapy clinical QA issues, including applicator motion, training, and organ motion. Applicator training is unbelievably important to making sure that you are delivering high quality brachytherapy to your patients. Physicians must know about applicator construction, applicator breaking down, applicator cleaning, and then insertion techniques. It's important to do your best to train at a place where you can achieve lots of insertion practice. In addition, we at the University of Pennsylvania have created some free training videos that we host on the ABS YouTube. If you take out your smartphone and you scan this QR code, you will go to some virtual reality videos that we have created that include some videos about cervix brachytherapy. If you have a inexpensive cardboard virtual reality viewer, you can take your smartphone, insert that in, and then you can watch a training video about insertion techniques. So physicians, again, are responsible to know about all aspects of these. And if you're unable to receive sufficient hands-on training, there is some virtual training that can be helpful. So you can scan this QR code and you'll jump right to it on the YouTube, and it's all free. Organ motion is also very important. The largest differences in brachytherapy plans are generally due to variations in bladder and rectal filling. Some clinics will place a rectal tube at the time of the procedure to ensure that the rectum stays empty throughout the treatment, and some clinics will aim for consistent bladder filling, including adding 100 or 150 cc's of fluid into the bladder immediately prior to treatment for consistent bladder filling through the Foley catheter. However, we've chosen to treat with an empty rectum and empty bladder because that, in our opinion, is the most reproducible, and it's also the least amount of effort. So we do our best to treat with an empty rectum and an empty bladder. And finally, before Shibu starts talking about some other QA challenges, applicator motion and immobilization. So it's important to minimize patient and applicator motion. It improves your confidence that your applicator has not shifted from insertion to treatment. And there are lots of different devices, and all of them work quite well in terms of improving your confidence that the applicator has not changed, including stretching stockings, commercial mobilization, brachytherapy boards, and external fixation clamps.
Anil, sorry to interrupt. Someone asked, could you share the QR barcode again?
Okay. All right. The QR barcode is up here. If you open up your phone's camera app, for most phones, it should come up. And these videos are also recorded, so the QR code we can find in there. And if you still can't find it on YouTube, look for the American Brachytherapy Society and the virtual reality videos. Thanks, Steve.
Thank you.
So the applicator can move in between patient transfers. You should re-image prior to treatment to verify to improve the confidence. And if there's any concern for movement, you want to replan your patient. So this is an example of a patient that has had some minor pitch changes during treatment that did not significantly alter the quality of covering the target, but you can see with some pitch changes, a little bit of bladder was being contacted by 100% isodose line, and now a lot more bladder is in the field now, and we replan this patient. There's, again, lots of immobilization options. There are very, somewhat expensive commercial brachytherapy boards, applicator holding devices that if you add straps, they can be strapped to the patient. This is a homegrown solution where one clinic creates a sling out of gauze and then wraps it around the shoulders of the patient. And this is a brachytherapy clamping device that allows the applicator to stay inside the patient. So I'll stop sharing and then thank you for listening, and Shiva will talk about some physics QA challenges.
Are you able to share, Shivu?
Yes, I'm just doing it right now. Yep.
Okay. Good.
Can you see my screen?
I think we have the presenter view.
Oh, the other view. Okay. Is it good now?
Yeah, it's good.
Okay. Thank you. Thank you, Dr. Tonk. And I will be covering some of the physics quality management issues in my talk. First, there will be some overlap with my previous talks. The external beam part, I will be covering briefly, touching, as I mentioned earlier, usually typical 4-field box. The more homogeneous doses compared to 3-field and 2 fields. Usually use high energy beams, specifically for lateral beams. For APPA, depending on the patient, you may use a low energy beams. If high energy beams are not available, you can use the low energy beams that is available in your clinic, but the field weighting, you need to adjust the field weighting so that more weighted anterior posterior beams usually to avoid the high dose to the lateral pelvis. And if there is a para-aortic treatment involvement, you can do a half beam technique. The lower pelvic region you treat with the 4 fields, and the upper para-aortic region you treat with the APPA fields. And for some patients, if you're worried about bowel dose, or if you're concerned about the bladder, we can treat also with a 3-field plan. It's a posterior beam and 2 lateral fields, and the PA fields usually a low energy field. And for these plans, as compared to the 4-field, you will be seeing the posterior hotspots, but you can manage the hotspot by adjusting the beam weighting and maybe adding field in field or segments or wedges to push the posterior dose to the anterior side. Typically, it's more lateral dose as compared to the 4-field, because the dose is divided into 3 as compared to the 4. But you can have better bladder sparing and bowel sparing. And if you're too concerned about the bowel, we may need to consider the simulation for the patient in the prone position on a belly board that will displace the bowel more into the belly board and because of the gravitational pull. Then for some patients, like have a hip replacement or a prior radiation to the hip, you may treat with the APPA fields. And also for patients, if the tumor extent is uncertain, you can use APPA. It's more usually for a palliative regimen. And as I mentioned earlier, nowadays we usually treat with the VMAT and IMRT technique, usually a 7-field IMRT or 2 full arcs. More conformal dose distribution to the target. Dose is very conform to the targets, better OIR sparing. And if you need to consider a simultaneous boost treatment to the nodes, this is more ideal, and it's more typically more ideal for hypofractionated treatments. And then I will switch to the brachytherapy section. For the brachytherapy section, for the preparation and planning, brachytherapy is more like a teamwork between your physician, physicist, and the therapy team, because the simulation to the treatment that happens within hours or on the same day. So I'm saying it's a more teamwork than compared to the external beam, because the external beam will be happening in a few days. The simulation can be happening on a day earlier or 2 days earlier, things like that. And usually it's better to discuss with the physician prior to the implant and come up with a planning plan. It is ideal to review the diagnostic image of the patient to see whether which applicator we need, and either interstitial applicator you need, or intracavitary, or a hybrid applicator is necessary. And prepare everything needed for the implant in advance. And if an ultrasound guided implant is performed, make sure the ultrasound QA is done and the ultrasound machine is ready for the use during the implant. And for CT simulation, from physics standpoint, we usually make sure the CT scan acquisition length. We try to acquire the full length of the applicator. Usually we acquire the CT at least 5 centimeters superior to the tip of the target, for the superior end of the target. And we try to completely capture the whole applicator. The reason is sometimes we may have a discrepancy in the needle length. You can measure it backwards on the CT and find how much of the needle is protruding outside the template. And for application positioning and assembly, you need to be, sometimes the applicator can be dislodged. So you have to make sure that's the applicator positioning and nothing is dislodged. Sometimes some patients may have rectal air, which may not be reproducible for the treatment. So may need to release with the rectal tube. You need to talk to the physician and release the rectal gas. And if you're using interstitial needles, sometimes you will see crossing of needles. Multiple needles may be crossing. It's not that common, but there is a chance that the digitization might get difficult. If the tumor is harder, sometimes the needles may deviate and there's a crossing can happen. So if the digitization gets difficult as a physicist, you make sure you use dummy wires to identify the right catheter. And sometimes you may need to use catheter like a dummy wires in alternate needles or every needles, depending on the goal is to identify the catheter during digitization. There is another issue that we notice is like sometimes there may be a needle obstruction. If there is a from implant to the sim, if you move to the patient to the simulation, there can be needle obstructions. You can try to check using with the thicker dummy wire to see whether it passed through, or it's if you know the needle has an obstruction and we cannot use it for planning, mark that needle and say we cannot use it so that we don't need to digitize that needles. And make sure the needle placement, sometimes the needle may be advanced too much past the target, or sometimes it will be a little shy. Then in that case, sometimes the needle may need to be pushed further in or pulled back depending on the case. So you need to discuss with the physician and arrange that. And after everything is confirmed, verify the needle position and lock the needles to the template or glue it to the needles, glue it to the template, and before acquiring the CT. And simulation, usually for interstitial cases, we use a template, needed template. This is just an example of the template that we use. which is showing the patient's name, MRN, and the orientation. And during the simulation, you circle the needles that you are using implanted. And if any of the needles you found an obstruction, if you need to exclude, you just cross that out. So then we don't need to use that for digitization. Then each needles you place an yellow leak stop. Usually we use an yellow color, any color leak stop button on each needle, which matches the channel number of the template. And fill out the table in the daily measurements document. And we have a baseline measurement from the simulation that we can use for verifying every day before the treatment. And for MR simulation and imaging, make sure the patient, if can get in the same position, make sure the patient in the same position from CT simulation. And remove any dummy wires or mandrels for safety, MR safety purposes. Make sure we remove before we move to the MR for simulation. And MR is usually mainly used for target delineation, and make sure the registration accuracy between the MR and CT. You need to discuss with the physician what's the region of interest, and you need to sit together with the physician and make the final adjustment for the registration before contouring the target. For treatment planning, for applicator digitization, you can use applicator library or templates, applicator templates if possible. And if you're using needles, you can use a line profile tool depending on your planning system. And make sure when you digitize, all 3 views are checked so that the digitization is accurate. If the template is not available, some of the vendors will provide templates in this planning system. If you can make your own templates, this is the template that one of our physicists made for our Kelowna applicator. You can see the picture showing the implant template created based on the Kelowna geometry and numbering system. The template has dummy screws, needles, and thumb screws. All has needle positions, which we make sure use for a better alignment. And after that, we can just remove those particular needles. After the final adjustment, you can remove those templates and screw needles. This will eliminate the need to manually insert. You can see this template, the needles are very close to each other and it's not in a pattern. Sometimes there is a chance of digitizing the wrong catheter to the wrong number. To avoid this, if you use this template, that can be safely, you can start the digitization. For treatment planning, sometimes inverse optimization can cause heavily loaded well positions. If it's using an inverse optimizer, or sometimes some of the positions may not be used. In that case, you can use the dose shaping tool, and for forward planning is helpful. Some needle position displacement can cause, if there are heavily needle dwell positions, a minor needle displacement can cause large variation in the OIR doses. So if possible, try to use all the dwell positions. Possible dwell position is ideal for a robust plan. And for applicator selection, this was covered earlier. You can use an interstitial intracavitary applicator, tandem and ring or tandem and ovoid. You get the typical pear-shaped dose distribution. You can use a hybrid applicator that facilitates the treatment for wider and asymmetric targets. This is definitely better for better target coverage and OIR sparing without requiring a full interstitial implant. Usually for implants targets with the 30 cc, you can use this hybrid applicator. You can see on the right side, the top picture, how nicely the dose is conformed for that. And if you are using then for patients with the poorly fitting intracavitary applicators or even larger lesions or lower vaginal involvement or recurrences, we switch to an interstitial applicator, which you can see it's better for the target coverage, and you can shape the dose the way you want using these needles. And this is just a hybrid embrace trial experience showing the data it's a retrospective study. They looked for 610 patients. I think 310 patients were from the intracavitary group and 300 patients from the hybrid applicator group. They found that the D90 for the high-risk CTV increased from 83 plus or minus 14 gray to compared to 92 point plus or minus 13 gray with the significant p-value. The average difference was like about 7 gray. And there was no difference in doses to the organs and risk were found. And the 3L local control rate in patients having the high-risk CTV volume greater than 30 cc was 10% higher with a significant p-value. And no difference was found for targets with the volume less than 30 cc. For treatment delivery, all routine QAs, and then make sure there's no catheter obstruction because overnight stay can cause catheter kinks. Make sure there is no catheter kinks. You can check obstruction using a thick dummy wire and applicate needle displacement, anything that's usually from your transfer from CT to the treatment. This can happen. So make sure that you can use your measuring template to verify that, and avoid transfer tube kinks and sharp turns. From the guide tube, when you use, if there is a sharp turn, the afterloader may not, we see an obstruction during the treatment and it may retract the source. Many times, we had a few times, we noticed the dummy wire may pass through if there is a small kink, but the source wire can fail. This is typically because of the nature of the source welded on the wire. And verify the correct transfer tube usage. Always make sure that, because the different applicators uses different transfer tubes. There was an incident in 2019 in Canada. There were 25 cervical patients were treated to the wrong position because of the wrong transfer tube use. And make sure to measure and record the free length of each applicator. So the template, we got it from the simulation. We make sure how much of the applicator is protruding outside from the template, from the template. We verify and record that. And make sure the total length for Gamma Med Plus, you use the applicator plus the transfer tube length is 130 cm. You use a guide wire to make sure that's 130 agrees. And perform your timeout procedure, and then for treatment, always perform the timeout procedure to make sure everything is safe. And for safety and time management, I just wanted to have one slide. I just want to mention use automation whenever possible. Use plan protocols. You can standardize your structures. You can build in your optimization parameters, and the plan evaluation tools all can be built in the protocols, and try to use the protocols if possible. And use applicator templates and library so that this will avoid digitizing the wrong catheters, and it's easy to make the plan quickly as well. And for time saving, for us in our workflow, we perform the OAR contouring and planning in parallel while waiting for the MR simulation done. Target contouring, final target contouring is done after the MR registration. Then usually at the end, you only need a minor plan change after the target, final target. And so you can start the plan with the point A and then confirm the dose based on, modify the dose based on the HRCTV. Always, as Dr. Dong and Dexter mentioned this, always use checklist. We use encounters in our record and verify system. And if possible, do second check by a second physicist and therapist. In our workflow, we have a second check done by physicist, and there is a therapist for treatment, making sure a second verification for the connections as well. That's it. That's all I have. Thank you very much.
Thank you, Shiva. Yeah, thank you. Thank you for all our presenters today. I think it was a wealth of information given in this session. So I know we have about 15 minutes for our Q&A. I just asked if all of the presenters for today could just turn their cameras on, and that way we can, I guess, put everyone together on the panel. Let's see. I know you don't have a camera, Dexter, if that's okay. I can still put your name up there. And I know is Julie and Dr. Shanez still with it? Yes. And also, is Julie still with us? Or did she leave? I don't see her listed, so she may have had to log off. Okay. Okay. So I know that there's, I know we've answered most of the questions. I'm just looking at the chat to see if there is any additional questions. I've asked everyone to add questions into the Q&A or the chat for our panel. I guess there is one question from Samuel where he says, for easy digitalization, what is your view about using 2D radiographs generated from this CT? I guess anyone on the panel can answer that question.
I don't have experience using the 2D digitization. Olden days, we used to do 2D digitization. Nowadays, we do 3D that is more accurate, right? So if anybody has any other comments.
So, sorry, Stephen, can you repeat the question again?
Let me see. So the question was in the chat. I was looking in the chat again. It says, so I can find it. Oh, for easy digitalization, what is your view about using 2D radiographs generated from the CT? I guess that's, I guess it was Samuel. I know if Samuel, if you're on, maybe you want to say a little more about the question.
Samuel, can you just elaborate on the question, because maybe my understanding may be different or our understanding may be different?
Yeah.
What do you mean?
Yes. Once we take the CT scan before the planning, the images are transferred to the treatment planning system. Now, on our treatment planning system on Eclipse, we have 3D brachytherapy and we have 2D brachytherapy. So once we generate, we get the images, we kind of generate a 2D autograph from the CT, which shows us the areas, the points that has been digitized. It shows the 2D arrangement. So with that, we're able to see where the dwell points are on the tandem and on the ovoid. And it's that's what we normally do in our center, and it's so clear. So if we have any points that it's outside that is outside probably the tandem or the ovoids, then we quickly go back to the 3D and we correct, we adjust. So that is what we do. Thank you.
And if I may ask, the brachy is done with the 3D. So basically you use the 3D as well. Technically,
exactly.
We something like a 2.5D. Sorry to use that word.
No. We do 3D.
Okay. Are you prescribing to point A?
Yes, we prescribe to point A. Yes. What I'm saying is just to check the accuracy of the dwell points.
Usually in the in the planning system, you have you can look the 3D view also, right?
Yeah.
If you can see where the direction of the applicator, all the dwells are, you can display. There are different display windows you can have. You don't need to get generated 2D view. You can just use the 3D view itself, just displaying the needles, just displaying the needle positions or dwell positions as well. So that way you can clean up if there is anything. And there is another tool, an auto detection tool in many of the planning systems which you can use. Sometimes it may not be that very good as compared to you manually digitizing it, because you will see sometimes the plastic needles a zigzag type contour which you may not like as a physicist.
I do have a question for the panel. I know that
Maybe a question for Sam will be, why does he go through this extra process? Is it an extra step that he wants to do, or it seems like since he has a 3D system, that is the best way to approach rather than going through this extra step to check the accuracy of the system. Sam, why do you go through that extra step?
We do that just for a check, because most of it place the dwell point when we digitize. Sometimes we do it manually, and it might not be as accurate as we want. So when we check the 2D aspects, it gives us another view of what we have done. So then we go back to the 3D and we continue with that plan.
Interesting.
So that's the two orthogonal views that's my mentioned. Make sure in all three views, right? That's a coronal and a sagittal and axial view you can look at the same time when you digitize. That's a feature in the planning system for 3D planning. So is that what you're mentioning? Sorry. Or you take a DRR, you mean?
Exactly. That's what I mean. Yeah.
Oh, okay. Yeah, we use that feature. When you digitize, you will be looking at all the other three views I mentioned in my talk as well. So that way it's not deviating from the correct path of the channel, right? That's what you mentioned.
Yes, exactly. Yeah.
Okay. Thank you.
I do have a question. I know that, again, we have 10 minutes left, and I know that we won't be able to get to all the questions, but if you have a question, please submit it to the chat or the QA, and we will try to answer it even after the session is over. I mean, we've heard a lot about the need for clinical trials, but we've also heard about differences in resources and equipment that people have in different regions. So when we talk about doing a clinical trial for hyperfractionation for clinical cancer, I mean, what, I guess, would be an ideal trial? Are we talking like a trial for 3D conformal, a trial for IMRT, a trial with brachy? I guess I'm trying to understand like what would be, I guess, if you had to pick, like what would be the first trial that you think that we should really look at or try to create, given the resources available, given the differences in locations around the continent? And maybe Shanaz, maybe you can start it off and then we can follow up with.
So I think at a basic level, I think definitely 3D conformal as opposed to VMAT and IMRT. I think one of the struggles that I have is when we have the capability of doing VMAT and IMRT, and we definitely do it, but we can't do it in all the patients. And I think it's just a huge staff resource and labor intensive, and you're trying to get as many patients through the system as possible. So I think at a minimum, I think 3D conformal, I think that will address a lot of the continent and basically, can be utilized widely. I think we definitely need to somehow or the other include diagnostic imaging. I mean, we definitely know that, the extent of disease is going to influence the outcome. So, it's not a matter of the patients doing poorly because the treatment is poor, is because of the disease being quite extensive as well. So some kind of diagnostic imaging has to be incorporated into that. And I think more than just ultrasound and a chest X-ray, I think at least a diagnostic CT scan where it's available. And then we can basically look at subgroups where we stage them, with some kind of diagnostic imaging and subgroups where we don't. But I think that would be the minimum. And I definitely think that most centers, I mean, no one in Africa that I know of does interstitial brachytherapy. I mean, we're hoping to replace our brachytherapy soon, and hopefully we're one of the few that will have that. But it's unfortunate that, we don't have that experience and we don't have that facility available. And most centers who do have brachytherapy will have two-dimensional brachytherapy at least, or some kind of CT volume-based brachytherapy available. So we can't really do adaptive. So I think at a minimum 3D, which can, if you do a good 2D plan as well, if you have a simulator, but most centers will have a CT simulator these days. And then definitely at least some kind of diagnostic imaging, because I think somehow the volume of disease does play a role and impact on the outcome, but we can actually tease that out and have two different groups for that. And I think that the other thing that we experience is, our patients don't tolerate concurrent cisplatin at full dose of 40 milligrams per meter squared. We did a dose finding study, and at the most that they will tolerate is about 30 milligrams per meter squared weekly. So we'll have to make into into that the option of having reduced dose chemotherapy, which might skew it, or might alternatively go for the full dose and see how the patients tolerate it. So I definitely think that would be the direction to go, and maybe initially do a test pilot project and see how that pans out, and then probably put into a full-blown study as such with comparative arms. But I think that definitely those will be the basic parameters that we'll have to have in place for us to successfully run a project like this for hyperfractionated. I think doing the VMAT with the image guidance and the cone beam CT and the daily adjustments and the doing a plan for different setups like full bladder or empty bladder, it's going to be definitely difficult for resource constrained centers in Africa. So I think that will be the best way to start.
So how can the I guess high income countries help and work with you? So like Neil or Shibu and these other speakers, I guess we're all from different areas to work together on such a trial.
Okay, I think definitely in terms of creating a uniform protocol. So what I think would start off would be to have a survey amongst all the centers that treat cervical cancer and would like to participate, and then see what resources they have available, and we work within that constraint. So we define what the resources are available. Maybe we can tier it as well. Facilities that have a little bit more resources will have a much more different way of following the protocol, and those that have more or less will have a different way of doing it. But I think that's the one way. So one is we need to do a survey and see what we have out there, and what patient numbers we're looking at and what resources we're looking at, and then adapt a protocol to fit that in, because you don't want to have too many variables otherwise. And then thirdly, I think we need to have some kind of guidelines, very strict guidelines in terms of how we plan them, so we maintain a uniformity. And then also in terms of testing the uniformity in terms of implementation as well. So I think one of the things that we lack is radiotherapy quality assurance, not in terms of day-to-day quality assurance as in practice, but in terms of seeing that the patients are following the protocols and there's no protocol violation. We don't have the kind of organizational skills to do that. So I think that will be very helpful way to start off that. I mean, if we are going to be developing a protocol for that, yeah.
Along the same line, Stephen, because of the volume of patients, talking about the African continent setting, volume of patients, as well as access to care. There are lots of talks about hyperfractionation, and that has a lot of benefit that we are seeing in prostate and say breast and others. So if you were to set up your ideal, a multi-institutional and a clinical trial where HFRT, putting in a high dose fractionation like Dr. Abba, he's doing that, right? At least, as you do other things, in parallel, if you're able to set up a clinical trial like that, what would your wish list be given some of the resources, in different countries? Look at South Africa, Nigeria. I mean, I saw some trials that you showed from Nigeria and Uganda in your presentation. It's looked like there are good resources in many of these countries, and it would be good to be able to do some multi-institutional clinical trial where high-income countries, like from this end, we can be of some help. You talk about radiotherapy quality management. Something we'd encourage you to think, maybe to see whether we can develop it together, and see and that will help, at least in terms of the access to care, and not only to mention the outcome of the patients that are treated there. And you talked about publication, also the lack of resources and stuff. So if there is a collaboration that we can establish, and it's not necessarily, I'm talking about African continent because you're the speaker from there. This is true for, there are a lot of global participants in this presentation, and this is a conversation open to pretty much everybody. One of our goal here is to be able, this HFRT session that we have organized, breast, prostate, cervical, it's really to develop collaborations and see how we can potentially help also, learn from you, as well as be work with you to see how we can all work together.
Yeah. I think across the continent as well, each country has its own challenges, so I think that we have to, I think if we form a network, we're having a conference next year, we're having a workshop dedicated to cervical cancer, and I know Surabhi is going to be part of that, and so we're hoping to basically meet with other African representatives and kind of develop a think tank or kind of a workspace where we discuss this, and I think that's a good platform to start. But I think we'll have to survey everyone's needs and capabilities and kind of incorporate that, even if it's in a tiered system. And I think that's the best way to start off with that. And I think from my side, I think the guidance would be, in terms of developing this protocol and setting the standards and knowing that there'll be different, levels to that protocol in terms of what other people offer and what others have, what others don't have, and then trying to inculcate this and establish that. And I think there's enough patients for us to do that. Absolutely, we've got a large volume of patients. Cervical cancer just overwhelms us, and our outcomes are not good. Really not good. And we have to do something to make it better. Definitely have to do something.
Well, I know we've come to, I guess, the end of this session, but I did want to give Neil, Shibu, or Dexter any final comments or remarks that you would like to make before we close out the session.
I'll start. Steve, thanks again for inviting us to be part of this. And again, it's been a tremendous learning experience for me. The comments have been really wonderful about this trial design. We're very happy to be a resource to local centers as they continue to grow their programs.
And thank you for giving me the opportunity too. And I work very closely with Neil and our team, and I'm happy to give all the support from my side as well for anything needed.
And Dexter, anything you would like to add or any closing remarks?
Just to say thanks again for this opportunity. And also, I'm not sure if the role of therapists, nursing, physicists is distinct as it is here in the US, but if there's an opportunity to lend any practice that we have, developing a checklist, some way to help to uniform the process if there is a trial, anything training I can help to provide to standardize the methods, I'm glad to help in that way.
Dexter, I have to say, as I have traveled, the different places, therapists always say, "What about us?" And so we have to remember therapists, because they always say, everyone talks about physicists and physicians and nurses, but no one talks about the therapist. So we definitely want to, include, you and everyone else, because you're part of the whole process.
Yeah, when I started the treatment delivery part talk, that's the reason Dexter is the one delivering the treatment for the external beam most of the time. That's why I included Dexter in the first part of the talk.
And in some places, the therapists, they are the dosimetrists. They do the treatment calculations and everything. And so the roles are different depending on where in the world you are. But I would like to let all our participants know next week we'll have a session on prostate cancer, and you can use the same link that you have now, so you don't have to worry about getting a new link. Just log in with what you have, and that will work for next week. It will be the same time as we had a session today. And again, I think these recordings will be available to everyone. Ahmad, I don't know if you had any closing comments before we close the session.
Oh, thank you. I think I would like to thank everybody for being with us this long and share and exchange the knowledge with everybody worldwide. And we are receiving so many messages on WhatsApp, on LinkedIn, on emails, asking about many details actually about the actual program, what's next, when will be the next session, and so forth. And we are collecting also all the questions that have been asked on the Zoom, and we are going to unify them in a organized manner, so that when we share it, aside from the videos, there will be some documentation as well out of each educational session. And I think it's going to be really, we will have good amount of knowledge that can be shared worldwide in cervical cancer and prostate and breast, and we will get this kind of events to continue, so that we'll make sure that therapists, physicists, dosimetrists, radiation oncologists, nurses, all of them are aware of all kind of technologies and how best practice can be, so that they can push treating cancer patients forward and make sure that since all of us have the same resources, so why don't we use the optimal, like use these technologies with the optimal possibilities, you know? So this is the beauty of having global activity, so that we bridge the gap between the professionals worldwide. And I would like to thank all the speakers, all the participants for being with us and willing to share their knowledge and learn as well. And thank you very much again.
And also thank you to Cordy, who is our editor, because behind the scenes, she does so much that
Yes.
We don't realize to make, you know, this session possible, that, you know, so we can get everyone together and get everyone coordinated, and to Bill and Katie and everyone else who works to make these things happen. So we definitely appreciate you and let you know that, you know, you're this, all this couldn't happen without you. This is a team effort here. So,
yeah.
So anything you want to say, Cordy, before we sign off? Okay. All right.
This has been wonderful. Thank you so much for all the participants. It's been amazing. Looking forward to the many more that we will have.
Thank you.
Stephen, I just wanted to add one other thing to this whole thing. You know, after the next session, which will be on prostate, we also have a contouring and treatment planning competition. I guess everybody is aware of that. This will be a global competition. We call it treatment planning activity. An important part of that is, you know, everybody participates and we'll select the, you know, top few recognize the top planners. And then there will be a session at the end where the top planners will be, you know, sharing their knowledge, how they arrive at the best plans, you know, all the tricks and tips. So I would ask everybody to spread the words around, you know, and this is actually our second, you know, initiative of this global activity of education and treatment planning all combined. So, you know, thanks again to everybody. I'll just join everyone else and spread the word around. You know, this is a good way to pull the entire world closer to each other.
Great. All right, thank you, everyone. Enjoy the rest of your day or evening, wherever you may be.
Thank you so much.
All right, thanks. Thank you.
See you next
Thank
week.
you, everybody.
Great day.
Bye-bye.
Thanks. Bye.
Goodbye. Bye.